Been given the cue that it's time to get started, and I hate to interrupt all the fun conversations that are happening, but you'll have a break and get back to that. Thank you all for joining us at the Rocky Mountain MS Center's Spring Education Summit. We're excited to all be here today despite the cloudy, somewhat rainy weather, so thanks for getting out and joining us. My name is Gina Berg, and I'm CEO at the Rocky Mountain MS Center, and on behalf of our entire team, I'd like to welcome you here to Anschutz Medical Campus this morning. This is an exciting year for us. The Rocky Mountain MS Center turns 40 this year, so we're kind of celebrating our birthday all year, and you'll continue to hear more about that throughout the year. One of the things you'll hear more about is what's been happening in MS in the last 4 decades, and we're proud to say that the MS Center has been part of those changes, contributing to research and advancing treatment practices that have fundamentally changed how we live with MS. Throughout our history, patient education has been a pillar of what we do. Our education summits strive to provide the MS community with the latest in research, treatment approaches, and strategies for living well with MS. We believe, and this is a cornerstone of a lot of what we do, that an informed patient is an empowered patient, and we're glad that you're here to learn with us today. I'd like to take a moment to welcome our online viewers specifically. We've had hundreds of people register to watch the live stream today from around the country and even from a few continents. It's exciting to be able to share this learning experience with people from around the world. Thank you all specifically for joining us. I'd also like to thank our exhibitors for today's event: Accorda, Biogen, EMD Serono, Genentech, Novartis Pharmaceuticals, Sanofi Genzyme, and Teva. Join me. And we'd also like to acknowledge our community exhibitors, Accessible Systems and Freedom Mobility. Please do take a moment to visit their display tables during the breaks if you haven't gotten to this morning already, and I believe they'll be here at the end. We've also received patient education grants and sponsorships from Genentech, Celgen, Sanofi Genzyme, Novartis Pharmaceuticals. And we're only able to bring you the Education Summit at no cost thanks to all of the support we get from these folks, so it's really critical. So one more time, thank you to them. Now I'd like to introduce Carrie Chahovic. She is our Director of Programs at the MS Center. One of Carrie's primary roles is the liaison between the MS Center's nonprofit and hospital staffs, and she's going to be serving as our MC this morning, so enjoy.
Wonderful. Good morning. Thank you, Gina, and thank you all for being here. We have a great agenda for you all today, and it really showcases the unique partnership between the University of Colorado, the University of Colorado Hospital, and the Rocky Mountain MS Center. This morning we'll feature 5 presentations from our MS specialists, and then we'll conclude the day with a Q&A panel. And that's when you'll have the opportunity to ask all the presenters any questions that you might have. An important piece of that is you'll notice the index cards that are on your table. Throughout the presentations, just jot down your questions that come up, and then volunteers will be circulating to collect those questions for the use in the panel. So thanks for filling those out. We will also have 2 breaks during the program. These breaks are an opportunity to enjoy refreshments and, very importantly, just connecting with each other and making those connections with fellow attendees. The complete PowerPoints and recording of this entire Education Summit will be posted on our website. That's mscenter.org. I'd also like to call your attention to an extremely important part of your packet this morning, and that's the evaluation form. That is very important for us, so please do take the time to fill that out before you leave today. And online viewers, be sure to go to our website to fill out the form there. There's a direct link in the YouTube description, so be sure to do that. Your feedback is absolutely essential in helping shape our education programming, and we have a task force dedicated to ensuring that your feedback is incorporated into our future programming. You can leave your finished evaluation forms either on your table before you leave or in the big blue box on the registration table there in the lobby. Finally, a few logistics before we kick off our presentations. Please do silence or power down your mobile devices. And then restrooms are located outside the auditorium and down the short hallway. And there's a second set of restrooms should you need it on the first floor, so the elevators down will take you there. If you'd like to learn more about the work that we do at the MS Center at any time, please don't hesitate to talk with any one of our staff members who are here today. We're all wearing these kind of white name tags right here to distinguish us, so we'd love to talk with you more. With that, I'd like to introduce Dr. Timothy Vollmer. Dr. Vollmer is the MS Center's medical director and co-director of the Rocky Mountain MS Center at University of Colorado. He has participated in more than 100 clinical studies in MS and is currently the principal investigator on 13 funded studies. Dr. Vollmer will be discussing the latest news in MS research, including hot topics from the American Academy on Neurology conference. Approximately 15,000 people attend that conference every year, and doctors from the Rocky Mountain MS Center at University of Colorado participate through presentations, speeches, and poster displays. So please join me in welcoming Dr. Tim Vollmer.
Thank you. Thank you for that. So I'd like to welcome you all here, those of you that are physically here and those of you that are watching us online. We hope the program is helpful and informative, and certainly would appreciate hearing your questions at the end so we can try to go a little bit more in depth. Before I start on the slides here, I just wanted to briefly review the Rocky Mountain MS Center and the programs we have here. So as you know, this is a collaboration between the Rocky Mountain MS Center, which is a 501c community-based organization, and the University of Colorado. And we're focused on the clinical and research side here, and then we collaborate with Rocky Mountain MS Center on education and advocacy and other aspects of our programs. So right now we have 7 neurologists, 3 advanced practitioners. We have somewhere between 4,000 and 5,000 patients that are being followed in our clinic. We have around 30 clinical studies. We don't have time to tell you about all of them, but we have staff and our colleagues that are outside the door to the right that can tell you about all the different research programs that are going on. Some are clinical trials of new agents. Some of them are looking at combination therapy, looking at reparative therapy, and some of them are biologic studies looking at how to diagnose MS earlier, or how to follow MS more precisely. So Dr. Carboy will talk to you specifically about a couple of our major programs, but if you do have questions, feel free to ask us or ask our colleagues outside the door. So to get started here, I'm going to be just doing a brief review of some of the things that have changed over the last year or so that are important for us as we move forward. So the first thing is just wanted to talk about the evolution of the concept of multiple sclerosis. This may not seem like this should be a major controversial area, but in fact it is in the field. Our field are made up of relatively obsessive compulsive people, and we tend to split things into smaller and smaller groups. And that's what we've done with MS. And the data I think now is evolving that the different forms of MS, relapse remitting, secondary progressive, primary progressive, and these other ones I'll talk about in a second, are not really different diseases. They're really the same disease, and their clinical expression is modified by the neurological reserve, or the size of one's brain. And it's a concept we won't go into a lot today because we've talked about it a lot in the past. But the concept of neurological reserve is becoming more and more relevant. It's more and more discussed around the world. It's something we've been promoting for about 8 years now. And it's a concept that really helps us both understand the nature of MS in terms of how it's presenting clinically, and also helps us understand the value of helping patients live a healthy lifestyle, which means a healthy diet and an active, busy life, including exercise. Right now, we have these 5 different terms, and just try to show them here. Are we projecting? Pete? There it is. Okay. So we're back up. So this issue here, when MS starts, is something we don't talk much about in the field, but we should, because the disease probably starts in many patients up to a decade before we see the first clinical symptoms. But there has been a new diagnosis that's come out in the last few years called radiographic isolated syndrome. This is a situation where patients have an MRI for a headache or some other problem, and it's instantly noted that they have white spots on the MRI that suggest they may have MS. And in the International Consensus Conference, this is discussed, and guidelines for diagnosis is discussed, but it's also said that treatment is not recommended for this because we don't know whether they work or not. Then there's clinically isolated syndrome. This is where a patient presents with their first symptom, but they only have one symptom. And historically, since 1860, to make this, Pete, we've lost it again. To make this diagnosis of MS, we wanted to have 2 lesions or 2 episodes occur separated in time so that we know it's a recurrent disease. And we want it to involve different parts of the nervous system. So that's called the clinical pathologic correlation. And it's held over historically because Charcot was a very influential neurologist back in the 1860s. But I would argue that now we're beginning to change and think of this as a biological disease. And hopefully that will help some of this. Okay, well, let me go back one. There we go. So radiographic isolated syndrome, I gave a presentation at the American Academy on this, and it was an international community of neurologists that were there. And the practicing neurologists function differently than the committees that come up with international consensus. And basically, we would argue we can make the diagnosis of MS at this stage by doing the cerebrospinal fluid analysis, looking carefully at the pathology, looking at risk factors. And in fact, we would treat at that point, the majority of us. In fact, if we confirm the diagnosis with CSF, 90% of the neurologists in that particular audience would go ahead and initiate therapy. So this concept, all these terms, I think will gradually be collapsed into whether you have MS, yes or no. And that's essentially where we need to go. Okay. Okay, so now I'd like to go briefly through a number of different topics, and it is brief, so if you have questions, keep track of them. The first thing I'd like to talk about is an advance in our understanding of immunology of MS, and this has to do with lymphatics. Can I get advanced? Okay, so just to briefly review the immune system, and you'll get more of this from Amanda. So the immune system we think about has 3 major components to it. The first one is just the barrier system, which is skin, saliva, tears, mucus, those kinds of things help prevent bacteria and fungi and viruses from getting into the body. The second part is called the innate immune system, and these are including a number of white blood cells, neutrophils, eosinophils, basophils, and these cells are pre-programmed to attack foreign invaders. So they already have the machinery, they have the way to recognize them, and they can attack immediately as soon as infection is detected. And then the third part, this is the part of the immune system that improves the efficiency of the immune response to any given invader. This is the part that learns from experience. And it's like the brain, it's the other organ in the body that learns from experience and can develop new capabilities. And this is the part of the immune system that actually is involved in MS. Traditionally, we've thought that the T cells were the drivers of the disease. Now we know B cells are very important players as well. And this immunology will be working out. Now, this immune system tends to be organized, I'm not being able to advance here. It tends to be organized in terms that there are some cells in the blood, but the large majority of immune cells are actually in tissues, and particularly in lymph nodes, spleen, gut, liver. And there's a system that connects those organs and monitors the entire body, and that's called the lymphatic system. So you have the blood circulation system, the vascular system, and you have another vascular system, which is called the lymphatics. And that system basically just drains fluid from tissues. So as fluids move out of the blood vessels into the tissues, it then returns to the circulation by entering the lymphatics and draining back into the bloodstream through the thoracic duct. But on its way to moving back into the bloodstream, this tissue fluid moves into the lymph nodes, so the lymph nodes is where all the immune system is, and the immune system surveys that fluid to see if there's anything abnormal in it that it should respond to. So if you have a local infection, say in the hand here, that will drain back in these lymph nodes in the elbow and under the arm, and that will initiate an immune response that will then send immune cells out to attack that, as well as make antibodies that will help you resist that infection. Now, if you look at this model here, you see that there aren't any lymphatics in the skull. And that has been basically religious doctrine in our field since the 1940s, when a relatively prominent neuropathologist made a statement in one of his papers that the brain was different than all other organs. It didn't have lymphatics. And as a result, nobody really investigated this question until a couple of years ago, when 2 groups, one in Virginia and one in Sweden, were actually looking in the brain with monoclonal antibodies that identify lymphatics, but for different reasons. They weren't really looking for lymphatics, but they found them. And in fact, the brain does have a lymphatic system. And the reason that that's important, oops, too hard here, is that it now gives us a way to understand how the brain is directly connected to the immune system, which can help us understand the immunology. So the old model was that spinal fluid dripped out through your nose, through the cribriform plate here, and drained into lymphatics that were in the face, and then went to the superficial lymph nodes that are under your jaw in front of your ear. And that's how the immune system surveyed the brain. So it was kind of an indirect connection. But now we know there are lymphatics that surround the meninges in the brain, so they're on the surface of the brain, and they're draining out spinal fluid through these lymphatics that go out through the openings in the skull where the major blood vessels go through, and they drain into what are called the deep cervical lymph node chain. So this lymphatic connection can move spinal fluid and anything that's in spinal fluid, proteins, cytokines, anything else, into these lymph nodes. It also allows immune cells that are in the brain to migrate out through the brain through these lymphatics and also go into these lymph nodes. Now, the major issue to understand here is that the key cell that drives MS is a B lymphocyte. And B lymphocytes live in lymph nodes. It's called B cell follicles there that help the immune system both survey for problems and also mount immune responses to them. It turns out that the B lymphocytes in the brain are all cousins of each other. They all are derived from the same founder cell. And you can study them by looking at the mutations that are made in the B cell receptors to connect them with this family. So you can follow this family of B cells in the brain and also in the blood. And more recently, a group at Yale identified that they're members of that same family in these deep cervical lymph nodes. And in fact, there were more of them there than there were anywhere else. And they were proliferating at a faster rate. So that tells us that it's very likely that there's something draining from the spinal fluid, either protein in it or immune cells, that then produce B lymphocytes in these cervical lymph nodes that can drive the disease. And the way that works is these B lymphocytes have to re-enter the circulation. Again, they migrate out through the lymphatics and move back into the circulatory system. They circulate back to the brain and they cross the blood-brain barrier, and that allows them to cause inflammation. So this is basically just telling us where the circuit is, and hopefully that will help focus research as we move forward to study those B cells specifically to identify what they're responding to and how they cause injury. Next thing is, MS is still called a demyelinating disease. I would like to have you disregard that term because it's totally misleading. MS does damage myelin, but it damages nerve cells even more. And those nerve cells are the ones that cause disability. That's the primary driver of disability. So it now is changing. And the field is beginning to think about neurons as a key target in MS, and we're trying to understand how the neurons are killed and what we can do to help prevent that. So traditionally, the way we thought about MS was that it would damage the insulation material around the nerve fibers, and that would lead to a problem where this demyelinated area had trouble conducting electrical signals to it. They would get blocked, and sometimes the axons would die. But now, what we're really focused on are the neurons themselves, and this is an immunobiology that I would propose fits the models the best. So think of this as a lining of a blood vessel, and this is the inner part of the blood vessel here, and lymphocytes, both T cells and B cells, are circulating in the blood. They move into the brain, and they cross the blood-brain barrier. And then once they cross it, these immune cells become activated, and it appears the B cell is the primary driver of that activation. And that generates a whole number of immune consequences downstream. But one thing that it does, which is important when we think about therapies, as I'll discuss in a few minutes, is that it also changes a cell in the brain called an astrocyte. Astrocytes are the most common cells in the nervous system, and they're there to support neurons and the myelin-forming cells. But they also are part of the immune system. They're part of that innate immune system, and they get activated. And when they get activated, they produce toxic molecules called tumor necrosis factor or nitric oxide and oxygen-free radicals through upregulation of an enzyme called INOS. And these factors damage the energy-producing structures in cells called mitochondria. And so we're beginning to recognize, and was emphasized in a recent review of pathology, that the brain in MS patients is energy-starved. And it may be because of this particular biology. So the brain's not able to produce enough energy to do all the functions that it should be doing. In addition, nerve cells and myelin-forming cells are cells that have huge cell membranes. They need a lot of energy to maintain those structures. So they're very sensitive to any kind of decrease in energy. And it appears that one of the major causes of death of these cells could be just the lack of energy being produced by mitochondria, so they're not able to maintain their integrity and they die as a result. And that actually gives us these molecules, the TNF and nitric oxide, as additional therapeutic targets. And in fact, we have several therapies that are in trials now that are targeting the astrocytes not the lymphocytes, but the astrocytes, to help downregulate them and inhibit their ability to make these toxic intermediates that are damaging the brain. So, and then the last thing about the biology is just the increasing understanding about how normal aging interacts with the MS disease process to give us the different clinical forms. And this is a slide that was presented at AAN, maybe ECTRIMS, about a year ago from the group in Southern California. And basically, they were doing volumetric MRIs, and they were looking at different structures in the brain in terms of how they were changing in volume over time. And then they corrected that volume change for what we know happens normally in aging. So unfortunately, all of us begin to lose brain volume around age 35 to 40. And that accelerates as we go through life, particularly in my decade. So that also has implications because, again, we've talked about this concept of neurological reserve where the brain can buffer for injury because it has extra capacity. But that extra capacity decreases over time because of the normal process of aging where we're losing nerve cells after age 35 to 40. Now, MS is also damaged in the nerve cells, but you can see that in age 30, most of the loss of brain volume is green, and that represents loss due to MS. But by the time we reach age 60, about 2/3 of the brain loss is actually due to normal aging. A smaller amount is due to the MS. Unfortunately, we don't really have much in the way of therapies for aging outside of diet and exercise. Those are the only two things we really have that may impact that we know about. And so out here, excuse me, we can treat the MS part and we can shut that off, but we have to recognize that underneath that is that normal aging process. And if we're really going to improve outcomes out here, part of it would be to shut off the inflammation from MS completely, but the other part is also adopting lifestyle changes that help buffer for aging. And as I mentioned, that's a healthy diet and an active, intellectually active and physically active lifestyle. And so that helps us understand why we get different results with these therapies depending on the age and the stage of MS that patients are at. And hopefully that will generate more thinking about additional therapeutic interventions we can do to improve outcomes and to help patients recover function. One really quick thing is the prevalence of MS in the United States doubled about a month ago. So the National Society has used a number, about 400,000 people in the United States have MS. That wasn't based on any really good data. There was a study that our group here did with John in the School of Pharmacy looking at claims data and insurance databases, large databases looking at millions of people, and estimated that the number of patients in the United States probably was closer to 600 to 800,000. And then there was another study, similar study done with claims database that estimates now is about 947,000 people in the United States. I suspect that's still low. Also, the prevalence of MS is actually increasing in the developed world. So Europe and the United States, the number of people who develop MS is increasing year after year at a slow rate. The exact causes are not clear, but it probably has to do with how our lifestyle changes as we become more affluent. So it was estimated about 15 years ago or 10 years ago that the cost to the US economy for MS was about $8.3 billion. But now the expense just for the drugs alone in the last year is over $14 billion. And then the direct cost of disability and other medications is probably another $8 billion. So we're probably closer to over $20 billion related to this particular disease. Now, to finish up here, then I wanted to go over a few advances that are coming through from a therapy standpoint. The first one are the anti-inflammatory therapies. So as you know, we have the interferons, maybe 5 different versions. We have glutaminyl acetate, Copaxone. Now we have at least three different versions, maybe 4. And then we have the oral medications, Albagio, Tecfidera, Gilenya, and then we have the infusible drugs, which are Tysabri, Ocrevus, and then off-label rituximab. But in fact, there's actually quite a few additional therapies that are in development. So this is just a timeline that I borrowed from one of my colleagues without telling him. And so it points out that beta-seron came out in 1993, Avanix, Copaxone emerged in 1996, then we've had a steady introduction of other therapies as we went forward. But these are therapies that are currently in development down here, and I'd like to talk specifically about them. So the therapies in development can be classified into 3 groups, and most of them are actually copycat drugs. They're not new, fundamentally new. They're basically similar to, in this case, Gilenya, or they're similar to the Ocrevus and the new anti-CD20 monoclonal antibodies. So just to review these, Gilenya, or fingolimod, is a drug that was approved about 6-7 years ago for relapsing and remitting MS. It has a complex mechanism of action. It basically blocks a certain receptor family called the S1P receptors. Those are involved in lots of different things in the body, but they're involved in the immune system in terms of sort of locking up immune cells in the lymph nodes. So we talked about those lymph nodes earlier. Immune cells have to migrate through them, and they use certain signals to get into them and to get out of them. And Gilenya blocks the signal that allows them to get out. So it doesn't kill the immune cells, but it locks them up inside the lymph node. And the second thing that it does is it affects those astrocytes that I talked about. So Gilenya can inhibit the activation of astrocytes in terms of that production of those toxic intermediate molecules that I mentioned. There's 3 other versions that are in development, ozanimod, ponesimod, and siponimod. And these are different from Gilenya mainly in terms of exactly which member of that S1P receptor family they interact with. So there's 5 different forms of S1P receptors, and Gilenya interacts with almost all of them except S1P2. And then the other ones are more selective. So ozanimod is more selective for S1P1, S1P5, and ponesimod is also relatively selective for S1P1, so is siponimod. And they're being studied in different forms of MS. So ozanimod and ponesimod are in relapsing MS, but siponimod has been studied in secondary progressive MS and actually succeeded in its study and is in the process of being reviewed by the FDA. The other drugs are about ready to submit or have submitted as well. So these are drugs that in the near term, next couple of years, maybe 3 years, will emerge most likely as optional treatments for MS. And the difference between them, we really have to find out in the future. Hopefully, the differences will be related to both safety and effectiveness. And we don't yet know whether there's any real advantages of these therapies down here. That's something we'll only find out once they emerge into the marketplace. Another 2 molecules that are being developed are ublituximab and ofatumumab. And these are monoclonal antibodies like rituximab and ocrelizumab that target a protein called CD20. And CD20 is a protein that's on B lymphocytes. And these therapies only kill B lymphocytes, and yet they're among the most effective therapies that we have, telling us that B lymphocytes play a very critical role in MS. Exactly how we will use all these molecules is mainly related to the way they're given. So rituximab and ocrelizumab are infused intravenously once every 6 months. Ublituximab and ofatumumab are given at different doses and potentially subcutaneous as well, which would allow patients to do a subcutaneous injection once a month or once every other week at home. So they're going to give us different ways of using the medications, but I would doubt that there's going to be any real difference in efficacy between them if you adjust for dose. Then the last drug is a new class of drugs called cladribine. This drug is also being reviewed for approval at this time and may be approved relatively soon if it hasn't been already. And this drug is basically an old chemotherapy drug. We started working on it back in the 1990s. We stopped working on it because it was given intravenously at that time and it was too toxic. And then a very brave company bought the rights to it and decided to try to develop it as a pill, which I thought would be far too toxic. But it turns out it's moderately effective, and its safety profile so far appears to be similar to the other oral medications. So it is a chemotherapy, can cause a decrease in immunity, which can increase the risk of infections. We don't yet know about cancer risk rates with it at this dose. And it can cause problems with other organs, particularly in the liver. But as I said, it's competitive with the other oral medications. It's about in the middle in terms of its effectiveness, so it's similar to Tecfidera. And so it may have a role to play as we move forward. Again, a relatively simple molecule that can be taken orally once a day. And then to finish up, just want to talk about the reparative therapies. So this is relatively new for us. We've been sort of talking about them for decades, but we've really not had much in the way of studies going on until recently, and now we do have several studies. So these are molecules that have been in human trials in MS as either neuroprotecting agents or remyelinating therapies. So biotin is a member of the B vitamin family. It's a coenzyme. Biotin has several effects. One thing it does is it increases the amount of energy that cells can make. And for the myelin-forming cells, that may be important for oligos to have more energy so they can make more myelin. And it also is involved in the production of fatty acids, which make up myelin. And so it may increase the production of these fatty acids, which may also help oligos make more myelin. And so it's being used primarily as a remyelinating therapy. In the clinical trials, it has been shown to preserve brain volume in one study. And in another study, it allowed patients with secondary progressive MS to improve in function compared to placebo. There's now a large international trial going on that we're part of that's looking at this as an add-on therapy to the anti-inflammatory therapies. The second one is alpha-lipoic acid. My change didn't come up. It's actually not a remyelinating therapy. That's an error on my part. It's a neuroprotective agent. Exactly how it works is not really understood, but it seems to inhibit the production of pro-inflammatory molecules, and it may also help oligodendrocytes and potentially neurons actually resist the impact of inflammation in the brain. It also has been demonstrated to preserve brain volume and induce some remyelination, and it's now being, they're planning a phase 2 trial to continue to work and look at clinical outcomes. Fasinumab is an old molecule. It's the antilingual molecule we used to talk about. It's a monoclonal antibody that targets a signaling pathway in the brain that tends to block remyelination. That's why blocking that signaling pathway, we hope we'll get some remyelination. So far, the studies with this have been either negative or indeterminate, but the study designs were not very good. They were using the drug in patients who still had active MS, which may be able to erase the effects of the therapy. So there are plans to reintroduce it in some different study designs, and hopefully that'll go forward. Clemastine is a histamine receptor type 1 blocker. You can buy it over the counter. It's called Dayquist or something. And so it's a allergy medication, like many other allergy medications, help decrease runny nose, itchiness, itchy eyes and things. But in an experiment where they were growing neural cells that make myelin in culture, they were able to do what's called a high throughput screening. So they basically just screened several thousand medications that are currently approved for other purposes in this to see whether they help those cells that make myelin grow in an in vitro cultural environment. And in fact, this is one molecule that came out that appeared to help those cells grow. So it has been studied in at least one study. It did seem to have an impact on improving remyelination and also increasing rewiring, reconnection in the brain and preserving brain volume. So whether it's going to have a clinical benefit right now, we're not sure. One study did seem to improve speed of walking, but it's also going into clinical trials. And then some older drugs that we had for a while, sorry about that, fingolimod, and then the new one, ozanimod. As I mentioned, these molecules, these S1P receptor antagonists, also can work at the level of astrocytes and potentially oligodendrocytes and neurons. And so they're now being considered as add-on therapies again to other anti-inflammatory therapies, I know. And then finally, the last couple ones, butylast. This is a molecule that's used in Japan for asthma. It's also used for certain other things. It inhibits a signaling pathway called phosphodiesterase, and that pathway is involved in promoting inflammation. And it decreases the amount of production of that TNF, one of those molecules I showed in the brain that prevents energy production. And it also may have direct effects on oligos and neurons in terms of preventing them from dying from the inflammatory process. And then the last one is a really interesting monoclonal antibody. And the GNBAC1 is monoclonal antibodies developed by a laboratory to attack these genes for these viruses in general are not active, they're silenced. But if you get a viral infection like Epstein-Barr virus infection, that can activate these genes and they will produce a protein called the envelope protein. And that protein has been associated in MS with more disability and worse outcomes. And so they developed a monoclonal antibody to bind to that, and the preliminary studies suggest that it did actually improve remyelination in the brain and brain volume. It had a complex effect on brain volume where brain volume went down a little bit faster, we think due to decreasing the amount of abnormal fluid in the brain due to inflammation, but it did seem to improve the myelination of certain pathways. So these are 7 therapies that are in trials or about to go into trials that hopefully will be available to help us improve function, help patients recover function over time, and will probably be used in combination with the other anti-inflammatory therapies we've talked about. So thank you very much.
Thank you so much, Dr. Vollmer. I would like to take just 1 minute to remind folks to be jotting down your questions because we will be circulating and want to make sure you get an opportunity to get your questions answered. And I would like to ask you to please join me in welcoming the newest member of our neurology team, Dr. Amanda Piquet. Dr. Piquet specializes in autoimmune neurological diseases, a discipline that leads her to study and treat MS and many closely related diseases. Her research interests include optimizing diagnosis and treatment for patients with autoimmune neurological diseases. This includes the development of standardized guidelines and protocols for the diagnostic workup and treatment for autoimmune encephalitis. She is also interested in the identification of biomarkers associated with autoimmune neurological diseases. She'll be talking with us today about neuroimmunology and how that larger field plays a critical role in our understanding of MS. Please join me in welcoming Dr. Amanda Piquet.
Great, well, thank you for that introduction. Is this? We good? Yeah. Awesome. Well, thank you for that introduction. So basically this talk is on a broader subject than just MS. We're going to be exploring neuroimmunology. We're going to cover some immune system basics. I know you heard about the immune system from Dr. Vollmer. We're going to go into a little bit more detail with a focus on antibodies. We're going to talk about how the immune system can affect the nervous system in more ways than just multiple sclerosis. We're going to go through and talk about different types of autoimmune neurologic disease, how this is different from MS, but at the same time, how does this relate to MS? And so you've already seen part of this before, but oops. Uh-oh. All right, I can't get the pointer to work. But on the left side of the screen, you can see the innate immune system. This is what Dr. Vollmer talked about, where you have basically the immune system that you're born with. It's ready to activate at any point in time when you get exposed to some type of virus or a bug. This immune system doesn't ask questions, it just goes right to work. Then you have the adaptive immune system, which is shown here on the right. And this comprises of B and T cells, which you heard about before. And the focus on the talk today will be these B cells right here in the middle. The B cells basically produce antibodies. This part of the immune system is the educated part of the immune system. You get exposed to a virus or a bug, your body learns about it. It takes some time to activate because you're learning, and then it has a very specific response back. So these antibodies are targeting a very specific bug or virus. And so what is an antibody? Well, an antibody is an immune globulin, or otherwise a protein that is produced by the B cells. And this protein is supposed to attack a specific virus, as you can see here on the left, or a specific bug. Now, what happens when you get autoimmune disease is that these antibodies misbehave, and for some reason they recognize yourself instead of a virus, so they attack your own body. And when you get autoimmune neurologic disease, that's when it attacks different parts of your nervous system. So what is autoimmune neurology? Autoimmune neurology is a very exciting field. It's actually one of the most rapidly evolving fields in neurology right now. They are diseases that are mediated by antibodies. So you produce these antibodies that recognize the immune system and attack itself. It can happen for many different reasons. Idiopathic means we haven't figured it out yet. Parainfectious, you can get to these diseases that occur in the setting of an underlying infection. Or cancer-related, and this is called paraneoplastic. And so you can produce these antibodies in response to your immune system recognizing an underlying cancer. And so this... Oh. Which one?
The top button there.
All right, awesome. This is a good slide to have it. So this looks like a lot of alphabet soup, but just let me break it down for you. This is the landscape of autoimmune neurology, and you can just see the explosion of antibodies that have been discovered just in the last decade. So the idea of a paraneoplastic syndrome is not new. It came before 1965. It was actually in the 19th century that neurologists recognized that you can get an immune system response in the setting of having an underlying cancer. The first antibody was identified in 1965. I have things color-coded here. So the first antibodies recognized were due to what we call the classic paraneoplastic syndrome. So they were discovered in patients with an underlying tumor. And these are all the antibodies highlighted in black. The field has changed. We now recognize that you can get these other antibodies, not related to cancer at all, but your immune system, again, misbehaving. And so these are all highlighted here in red. And I'm even missing one for 2018. This field has really rapidly expanded, particularly after 2007. Now, you can also have antibody syndromes that look a lot like multiple sclerosis and present like multiple sclerosis, and that's highlighted here in purple, NMO and MOG. And I'm going to talk a little bit later about those two specific diseases. So how do patients present with autoimmune and paraneoplastic disease? Well, it can look like really almost any other disease in neurology. These diseases masquerade as traditional neurologic syndromes. They can have various presentations. Some of that we call coriform movements, where you have involuntary movements of the arms or the legs. So again, what part of the nervous system is affected? I'm going to walk you through. It can pretty much affect anywhere along the neuroaxis. So starting up top with the brain. If the brain or the cortex is involved, you can get encephalitis. Encephalitis is a disease that causes memory problems, cognitive problems, behavioral problems, things like hallucinations. You can get seizures. If the balance part of the brain is affected, so back here, you get a syndrome called cerebellar atrophy. This causes problems with walking and visual impairment, and many times balance issues. Not shown well in this picture, but deep in the brain is something called the basal ganglia, and when that is affected, you can get movement disorders. So again, very similar to things like Parkinson's disease that we call Parkinsonism. You can also have abnormal movements that we call coriform movements. When the brainstem is affected, there's a very specific syndrome called opsoclonus myoclonus, where you have jumpy eye movements. You can also get a brainstem encephalitis. And then the visual system can be impaired. And when this happens, if it affects the retina, you can get retinopathies. It can affect the optic nerve, and you can get things like optic neuritis or optic neuropathies. And these syndromes can present very similar to MS. The spinal cord can also be involved, and when you have the spinal cord involved, that can cause a myelopathy or a myelitis, inflammation of the spinal cord, and that results in symptoms like weakness, sensory changes, bowel, bladder symptoms. Here we're going to take the spinal cord in cross-section, and if you look at the spinal cord in cross-section here, you have nerve roots that come out. And at this point, you're leaving the central nervous system and you're going into the peripheral nervous system. And the peripheral nervous system can also be involved in antibody-mediated diseases and inflammatory diseases. And so if these nerve roots are involved, you can get what we call paraneoplastic radiculopathies. You have a little ganglion here, which is basically a nerve cell, and you can get that affected, which is called a sensory ganglionopathy. And when patients present with this, they tend to have profound sensory symptoms, so bad that it's actually difficult for you to sense where your body is. If you close your eyes, you can't really sense where your body is in space. And so these patients tend to have a lot of problems with walking. Very, very rarely can you get this part of the spinal cord involved called the anterior horn. And you can get mimics of anterior horn disorders. One very prominent anterior horn disorder many people know about is ALS. But again, that is pretty rare. And then walking further out, you have peripheral nerves. So if the peripheral nerves are involved, you get peripheral neuropathies. You have a communication between the nerve and the muscle. This is called the neuromuscular junction. When this is involved, antibodies can interfere with that communication, and you can get something called myasthenia gravis or Lambert-Eaton syndrome, and the latter is usually related to potentially underlying cancers. When the muscle is involved, we call this a myopathy or myositis, which is inflammation of the muscle. And then last but not least, you also have an autonomic nervous system. So this is the part of the nervous system that communicates to all your vital organs. So when the autonomic nervous system is involved, you can get changes in heart rate and blood pressure. You can get your GI system involved, which means patients can have constipation, early satiety, and motility issues in the gut. It affects your sweating ability, and you can actually get the loss of the ability to sweat. And then also bowel and bladder dysfunction. So are there risk factors for autoimmune neurologic disease? Well, yes. You can have coexisting autoimmune disease, so systemic autoimmunity. This can be in the shape of thyroid disease, type 1 diabetes, lupus, or other rheumatologic disorders. It is not uncommon to see a family history of autoimmune disease. As I talked about before in the setting of paraneoplastic syndromes, sometimes there's an associated cancer. So things that put you at risk for cancer, such as smoking, could put you at risk for one of these disorders. And then sometimes there's none. And that's what I related to before with the idiopathic syndromes. So we haven't discovered, what the risk factor is yet. So I'm going to take a step back and talk just a little bit more than just antibodies. So we're going to dive into some examples of inflammatory neurologic disease. Again, these diseases can affect anywhere from down to the brain to the muscle in the neuroaxis, but they're not a specific antibody that we know that causes these syndromes. And this is just a fraction of the list of things that can cause inflammatory neurologic disease. Rheumatologic disease being a very common one. And typically rheumatologic disease causes systemic symptoms, but it can also affect the nervous system in a small percentage of patients. And examples of these would be lupus. And lupus can affect the brain, can affect the spinal cord and cause myelitis. Those are common presentations. Also can cause neuropathies. Same thing with Sjogren's disease. Very commonly you can see neuropathies with Sjogren's disease. Sjogren's disease can sometimes have brain MRI that can look very similar to MS, and many times we're differentiating that and we're doing blood work to make sure we rule that out. Sjogren's disease comes with the hallmark of dry eyes and dry mouth. Now, antiphospholipid syndrome. This is an antibody syndrome that makes you more likely to form blood clots. It's seen many times overlapping with lupus, but it doesn't have to. you can see this disease on its own. And so when we see neurologic involvement, because it causes blood clots, it's not uncommon patients can present with stroke or stroke-like symptoms. We can also see spinal cord involvement too with this particular disease. And then there's other rheumatologic diseases, so rheumatoid arthritis and other connective tissue diseases. Here on the right, these diseases are a bit more rare. So neurosarcoidosis. Sarcoidosis is a systemic inflammatory disorder, and in about 5 to 10% of the cases, it can actually affect the nervous system. Sarcoid can really, it's a great mimicker in medicine because it can really affect anywhere in the body. Most commonly, you see it in the lungs with something that we call granulomas. But it can affect the eyes, it can affect the skin, it can affect the heart, and rarely also affect the nervous system. And it can cause lesions in the brain and lesions in the spinal cord, again, that can sometimes present very similarly to multiple sclerosis. Pachymeningitis, this is kind of an umbrella of different diseases, but we call it pachymeningitis because what it means is inflammation of the pachymeninges, and this is what overlies the cortex on the brain. Vasculitis, this is a inflammatory disease that affects the blood vessels. Now you can get primary CNS vasculitis where it's only affecting the blood vessels in the brain, but more commonly you can get systemic vasculitis that you can have blood vessels anywhere in the body involved. And as you can imagine, if it affects the brain, that can lead to things like stroke. Susac syndrome is very, very rare. It's a type of vasculitis. I just put it up here just because, again, this is one that sometimes we need to differentiate between MS. Susac syndrome leaves white spots in the brain, in the corpus callosum, that can sometimes mimic multiple sclerosis, but it comes with other symptoms that make us think that maybe it's not MS, and this is hearing loss, and this is very specific visual loss in the eye from tiny little blood vessels being involved. And then Behçet's disease is a systemic disease that normally causes a lot of ulcers in the mouth and in the genital region, and can sometimes affect the brainstem and the cerebellum. This one seems to be pretty highly correlated within a certain genetic population. So how common is autoimmune disease? Well, if you take a step back and you look at all autoimmune disease, all comers, so not just nervous system involvement, but including rheumatologic disease, autoimmune diseases of the skin, of the GI system. So all autoimmune disease, you're looking at 5 to 10% of the population worldwide. Just to break this down in terms of numbers, so you heard from Dr. Vollmer, maybe I estimated a little bit higher, but closer to 1 million people, probably in the US, living with multiple sclerosis. Now, to take a very well-known autoimmune neurologic disease called neuromyelitis optica, which I'm just going to talk about in some subsequent slides here, that looks very much like MS. Before the antibody was discovered in 2004, we basically diagnosed those patients with MS. It's much, much rarer. So you're looking at about 1 to 2% of that of MS in the US. So most of the people here today are here because they either have MS or have a loved one with MS. So I want to make sure I address this question. So I have MS. Am I at risk for other autoimmune disease? Well, not necessarily. So most autoimmune conditions affect fewer than 5% of patients with MS. Now, there are some exceptions to this, and that's celiac disease, type 1 diabetes, thyroid disease, uveitis, which is a very specific inflammation of the eye, and psoriasis. These diseases are thought to be greater than 5%, with thyroid disease and psoriasis being the most common. And it's probably because there is some underlying shared genetic susceptibility to these diseases, and perhaps some also shared environmental factors. Again, smoking being a big one. So now we're going to talk a little bit about examples of autoimmune disorders specifically that can mimic multiple sclerosis. And so just to bring you back to this slide again, the focus here is going to be on NMO, or neuromyelitis optica, and MOG antibody-related disease. Myelin oligoglycoprotein. That's why I say MOG, too hard. So neuromyelitis optica, or NMO. This is an autoimmune disorder that is distinct from multiple sclerosis, but it is not uncommon for patients to be misdiagnosed with MS. Like I said, before 2004, we did not know this antibody existed. And the specific antibody, the NMO antibody, is called the aquaporin 4 antibody. So this is what we do to test, and it's a blood test. Patients, the reason it's a MS mimic is patients often present with optic neuritis and spinal cord lesions. Now, the optic neuritis is often different from multiple sclerosis because it tends to be a very severe optic neuritis where patients can actually be completely blind. And it has very poor recovery, so patients don't always get their vision back. Some patients get optic neuritis simultaneously in both eyes. And again, that's another clue that maybe this is not your typical presentation for MS. The spinal cord lesions are also different. So the spinal cord lesions tend to be long, single lesions. As you can see here, it goes through 4 vertebral lengths. These are the bones, the vertebrae. And you can see that there. While in MS, you tend to have one, maybe multiple smaller lesions that are closer to the size of just one of these vertebrae. This is a little bit of a busy slide here, but just to emphasize why is it important to differentiate NMO from MS? Well, the treatments somewhat overlap, but at other points are very, very different. And so what do I mean by this? Well, acute therapies are very similar. We start with steroids. Typically, we do 5 days of IV steroids. If that's not effective or the attack is very severe, we move pretty quickly, because we know these attacks can be quite devastating, to something called plasma exchange, or PLEX. And what plasma exchange is, for those of you who may not be familiar in the room, you get a catheter in, just like dialysis, and we basically filter the antibodies out of your blood. So you can think of it as dialysis for your antibodies. Now, chronic immunotherapy, there is some overlap here with MS, but again, there are some things that are very different. So the majority of MS disease-modifying therapies do not work for NMO, with the exception of the anti-CD20 therapies, specifically rituximab. And rituximab is pretty much the mainstay treatment that we use for chronic immunotherapy in NMO. Unfortunately, to date, we don't have any completed clinical trials in NMO because it's such a rare disease. But the exciting part of the field right now is there's actually 3 phase 3 trials going on right now. So stay tuned, maybe next year or next summit, I'll have some answers. And then just to touch on MOG antibody-related disease. So this disease can present very similar to NMO. MOG antibody likes to attack the optic nerves in the spinal cord, just like NMO. Patients would get reoccurrent optic neuritis, and we would test them for NMO, but the antibody would be negative. And we found that in a small set of these patients that we called seronegative NMO, meaning we didn't identify the aquaporin 4 antibody, we're now learning that this is due to the presence of an anti-MOG antibody. And this antibody, while it's been discovered, I showed you on that slide, around 2000, I think it was 6, it's only commercially available since the fall of last year. So even though we knew about these antibodies, we didn't have the best way of testing for them through laboratory testing. And now that that's available, I think we're going to continue to learn a lot about this antibody. And at this point in time, we don't know what the best treatment is because we're still learning. So just some take-home points. Autoimmune diseases of the nervous system are important to recognize. They can present very much like multiple sclerosis, and yet they can also be very different. These presentations are very diverse, so you have to really do some diagnostic workup and listen to patient histories and really think about these diseases where they can easily be missed. And it's important not to miss them because we realize that these diseases are very responsive to immune therapy. So there are treatments available, and the faster we recognize these diseases and get patients on medications, the better outcomes we're going to have. Thank you.
Thank you so much, Dr. Piquet. Appreciate that. And if this is a topic that interests you and you'd like to learn more, you can also find a 1-hour webinar on our website discussing this in more depth. Dr. Piquet led a webinar called Emerging and Evolving Field of Neuroimmunology. So at this time, we are going to take a 15-minute break so you can enjoy conversation and grab some refreshments in the lobby. I would like to say we are a little crowded in the back, as folks in the back are experiencing. So if you have a seat that's empty next to you at your table, if you can either sort of raise your hand just to let people know that there's more space, that's great. And then also, if you wouldn't mind, if there's a granola bar on your table that you can just set in the chair, that way people know it's an empty space if they're looking up front and we can kind of circulate in more. Thank you. You know, it's a solution. We'll work with it. So with that, again, please leave your questions with your volunteers that are circulating, and we'll have the Q&A at the end of the session. So want to make sure to get those in. Thank you so much. We'll reconvene in 15.
I'm just going to leave that. Are you familiar with that?
All right, everyone. We're going to go ahead and get started so that we stay on track. So hope you enjoyed the break, and I would like to now introduce and welcome Dr. John Corboy to the podium. Dr. Corboy, thank you. Dr. Corboy is the co-director of the Rocky Mountain MS Center at University of Colorado. His research interests and projects include novel therapeutics for MS, treatment decisions in MS care, understanding how long to use conventional DMTs, and defining risk factors for the development of MS. Today, he will be discussing understanding early MS and how early detection can have a big impact on the ways that we treat this disease. Thank you very much, and welcome, Dr. Corboy.
Thank you, Carrie. Appreciate everybody coming out. It's kind of a dreary day by Colorado standards, but we still appreciate everybody coming out. I'm going to try and go around the front here. Those are my disclosures. We've talked about in the past that one of the major goals of MS therapy is lifelong brain, and I also throw in spine health. You've seen from Dr. McKay as well that the spine is an integral part of the central nervous system as well and is absolutely affected in many MS patients. But this is our lifelong goal, and the question is, how do we get there? And there are a number of different approaches, just in a very broad sense, many of which have already been discussed with Dr. Vollmer especially. So for example, starting at the very beginning, if we could identify the cause and avoid developing MS, that of course would obviously be most optimal. What we presently have primarily are these immune system modulators or suppressors, those things that somehow change or alter the immune system and can have a positive impact on the inflammatory component of MS. But as also described by Dr. Vollmer, there's neuroprotective agents. We might try to enhance normal repair of the central nervous system, remyelination and other things. We might want to try to replace damaged cells. Perhaps stem cells in the future may have a role there. And then a variety of good behaviors. And this is avoiding and treating comorbidities, that is other conditions that may worsen your overall function, diabetes, high blood pressure, other conditions like that. And then as well, exercise, not smoking, good diet, maintaining a good body mass index. And this gets at the wellness component to MS, and we're in the process now of developing a significant wellness component. We've gone through with our colleagues from the Jimmy Huga Foundation who help support a pilot program to develop wellness aspects having to do with nutrition, exercise. You'll hear more about exercise and physical therapy with Dr. Hebert later, and a variety of other approaches that we think are extremely important. And we hope to go forward with this over the course of the next year and have this expand to essentially everybody who's interested in doing it. But many different approaches that get at how we can attack MS. And this is probably a diagram that some of you have seen before, and this is just the cartoon of what happens throughout the lifetime of somebody with MS. And we can identify all of these preclinical or subclinical activity, early single attack, monosymptomatic attack, relapsing MS, progressive MS, and you could substitute as well here just progressive, because primary progressive, secondary progressive, probably the same thing. But as noted by Dr. Vollmer, this is all one large continuum. These are not separate disorders. This is one condition that just flows and changes throughout people's lifetime. And importantly, the first time that we see the patient is typically when they've had a single event, an optic neuritis, a spinal cord syndrome, or something like that. And then this becomes apparent to the patient. They go to their doctor, they come to see us, and that's what we think of as the first or initial demyelinating event. Over time, oops, got a little fast there. Trigger finger. So over time, people may have more relapses, and then further over time, the relapses tend to diminish relatively in significance as people may or may not have slow worsening of symptoms over time. In addition, if you look at just what happens with disability, most of the disability accrues later in life. And this is very important because when people are younger, we know that they have significant amount of brain reserve, cognitive reserve that allows them to recover. Many people, even after an optic neuritis, can get very good vision back. But as people age, this reserve goes down. And that's when people have the slow worsening oftentimes and progression of disability. We know that if we just look at the MRI scans, the little white dots, the accumulated T2 lesions, those accumulate slowly over time in conjunction with this. The new active lesions, though the so-called gadolinium-enhancing lesions, tend to be much more prominent early, and those diminish over time. So relapses diminish over time, and the active inflammatory lesions diminish over time, and paradoxically, we see that disability increases. So there's a disconnect between those two things. And this is also then associated with worsening cognitive function over time. And then finally, brain volume. Brain volume is extremely important for a variety of different reasons. As Dr. Vollmer noted, all of us, beginning about age 35 or so, have a shrinkage of brain volume, also spine volume for that matter as well. And over time, you have a certain amount of reserve, but that reserve is diminished. And we could see from that nice figure he showed from our colleagues at USC that there's both brain volume loss due to MS and brain volume loss due to aging. We cannot do, at this point in time, much about the brain loss due to aging. The goal then is to try to have the biggest impact when we can have an impact, which is often very early in the course of the illness. So this is sort of the broad view of what may or may not happen, and our goal is to try to interrupt this as much as possible. And today, I'd like to focus on the subclinical or pre-symptomatic or asymptomatic, very early portion of MS, where there may well be some loss of brain volume, there may be some cognitive impairment, there may be these early lesions that are seen. But there's no obvious overt symptoms that are typical of MS at that time. So this might be referred to as the MS prodrome. You can see clinical prodromes throughout medicine, throughout your body over your lifetime. And in MS, we think of this as sort of preclinical MS, and it's manifested by a variety of things that over the last couple of years have been identified in people who have not yet developed a classic first symptom of multiple sclerosis. And I'll go through all these and I'll show some slides, but decreased just overall activity levels, decreased cognitive function, increased problems with mood and anxiety issues, increased use of healthcare resources from our colleagues in Canada. Importantly, MS lesions that look just like MS, so-called radiologic isolated syndrome that Dr. Vollmer introduced earlier, is perhaps the very first overt sign of what we can see and quantify, so-called radiologic isolated syndrome. And also brain volume loss, and I'll show you that that occurs also very early in comparison to those who do not have ultimate MS. So this is from the Nurses' Health Study. It was published a couple of years ago and showed an individual, this is a study that's been going on for 40 to 50 years now, and women, they're all women, nurses have been every, I believe, 6 months updating what their activities are, what their height and weight are, what they eat, and a variety of other things. And then they're monitored just with this survey over time, and some number of them have developed multiple sclerosis. And what's been identified is that in this, many things have been seen in this study, but in this particular one, this is the time point from first MS symptoms years from diagnosis, and you can see that even before that, activity levels, and this is differences compared to people who are age and sex matched, but who did not develop MS, activity levels go down prior to first symptoms and prior to diagnosis. And that suggests that there are probably some very early subclinical signs that just activity levels alone are going down. There are a variety of different ways that you might be able to look at effects on cognitive function that are very early. So this is from Dr. Lebrun. She and Darren Akuta. Lebrun is from France. Darren Akuta is now at UT Southwestern. And they have developed this concept of the radiologic isolated syndrome, individuals who've gotten MRI scans for other purposes, oftentimes after trauma or mostly with headache, but their MRI scans look very much like multiple sclerosis, and a whole series of studies have flowed from this concept. One that Dr. Lebrun highlighted back as far as 2010 was just looking at cognitive function in individuals who had no overt signs of MS, but had these abnormalities on MRI scan, and compared RIS patients, also MS patients were looked at, and individuals who were so-called healthy controls. And the healthy controls were considered the baseline, so they were normal on 13 different cognitive tests. But then looking at the exact same cognitive tests to look at individuals who were significantly lower on any one of these 13 different tests, you can see that a significant number of both the MS patients and the radiologically isolated syndrome patients were abnormal or lower in function. Several of those, if you look at the RAS compared to just MS, a couple, the MS patients were worse, but many of them were not. Similar kinds of findings between the two. And if you look at the combination of RIS and MS compared to healthy controls, on over half the different studies, or almost half, 6 of the 13 different studies, they were significantly lower. And many of those were the RIS patients. 16 of 26 RIS patients were at least 2 standard deviations below the mean for what was seen here with the healthy controls on at least one of these 13 tests. So already, they have some cognitive issues. This is also seen in a couple other different studies. This is from Argentina. In Argentina, everybody gets standardized tests in what we call sophomore, junior, and senior year of high school. And you could follow those, and these are standard nationalized tests. Everybody has their scores published. Not published, but they're available. And if you look at individuals who ultimately are diagnosed with multiple sclerosis compared to those who are not over the course of the next 10 years or so, you can see that in sophomore, junior, and senior year of high school, compared to controls, individuals perform less well on these tests. Similarly, in Norway, where there's an obligation to perform military service, at age 18, individuals have a standardized test that's performed. And if you look at individuals who are diagnosed with MS compared to controls, the individuals who performed lower on the test were 2 to 3 times more likely to develop MS within 2 years of getting out of high school and starting their obligation to the military. All of these suggest that these are early signs that you can see already some subtle signs of MS. This is from our colleagues in Canada, showing if you, again, look at individuals over a lifetime, and they have these large databases, several of them in Canada, one in Ontario, one in Vancouver. This is from the Vancouver group. And you can look to see that use of healthcare resources, this is where the first demyelinating event occurred, optic neuritis, spinal cord syndrome, or whatever. You can see that before that, the rate of using healthcare is not terribly different, but goes up in the year or two before, and this is based on hospital admissions, physician claims, and use of various different medications. They all go up in the year or two before someone's had their first event. So again, subtle signs that there are things that are abnormal even before the first clinical event. And we can see this on MRI scan. This looks like a typical MRI scan of someone with MS. In fact, that's exactly what that is. But here's a radiologic isolated syndrome patient. And this is someone who has what's referred to oftentimes as dirty white matter. No discrete lesions, but just some fuzziness in the areas where we typically see lesions. In the Akuta studies, smoking and obesity with radiologic isolated syndrome were risk factors for having 9 or more lesions, for example, with obesity on these scans. And this is a very typical looking scan for multiple sclerosis. What about brain volume? I mentioned before, brain volume is extremely important. We know that brain volume is an issue because brain volume is arguably our single best MRI monitor of what's going to happen over time as a predictor of disability. Numerous studies have been done looking at brain volume in all aspects of MS as a predictive marker and other factors. These are patients with radiologic isolated syndrome, no symptoms typical of MS, get an MRI scan, looks like MS. Already their total brain volume, this is radiologic isolated syndrome, this is clinically isolated syndrome, someone's had a first clinical attack, both are lower than similarly age and sex matched individuals who have vague symptoms, not like MS. Similarly, we can see that the place that the brain volume is most important to have lost is in the cortex. As Dr. Vollmer mentioned previously, the gray matter, the outside, the cortex portion of the brain, and perhaps the deeper gray matter, is probably more important for disability over time than the so-called white matter, even though we still continue to call this a demyelinating disorder where the myelin wrapping, which looks white, is affected. It surely is affected, but disability is more affected with cortical abnormalities, and you can see already cortical volume loss. In a second study, people looked at a variety of factors with the spinal cord, and this was published more recently, just a couple weeks ago. And again, brain volume loss was lower in those who had radiologic isolated syndrome compared to healthy controls. Similarly, you could not really see that, though, with cross-sectional area of the spinal cord, in spite of the fact that 71% of the people also had spinal cord lesions in this study. But there are some other factors of subtle abnormalities, including what's called MTR, magnetization transfer ratios, that might be slightly different between RIS and healthy controls. So the brain volume, for sure, this is another confirmatory study showing is very important. We don't know yet about the spine very early. And then finally, when someone has their so-called first clinical event or clinically isolated syndrome, is it really their first event? In this study, which I believe is from France, they had 178 patients where they had a first demyelinating event, and then they went to see a doctor, and they filled out a questionnaire, and through going through the questionnaire, talking to the patients, examining the patients, it turns out that even though there were 178 patients that said this was their very first event, actually 59 patients, or exactly a third pretty much of these patients, when you actually talk to them and figure out what was going on, they've actually already had a first event. So even though they never made it to the doctor, or maybe they had some numbness, they made an appointment with their primary care doctor. By the time they could get in, the numbness was gone, so they canceled the appointment. We hear that over and over and over again. So the so-called first event is oftentimes not the first event. All of this gets at the point that there's not only a prodrome before MS, but before the individual ever makes it to see the physician, they've often had all sorts of different things that are going on. And so fundamentally, from the MRI scan point of view, we can call this, when we see these lesions on MRI scans, when someone's not had a typical first attack of MS, as noted, that's referred to as radiologic isolated syndrome. So what happens to these people? We know when someone's had a first clinical event that that's a very strong predictor, and there are a number of markers and other things that have been looked at that may or may not be relevant to predicting another clinical attack and or disability over time. But what about with these guys? Is it really the same? Well, if you follow people over 5 years, and again, this is from Lebrun and Akuta, the two that have been leading this throughout the world, that at about 5 years, individuals will have a clinical attack, and these people are all untreated. About a third will have a clinical attack, and that's very similar to the optic neuritis treatment trial, someone who's already had an optic neuritis. And if you follow them, about a third at 5 years will relapse. But notably, in the optic neuritis treatment trial, you can predict people who are more likely to relapse early. So for about half will relapse if they have 3 or more brain MRI scan lesions. We've known for years that with a clinically isolated syndrome, a very strong predictor of more clinical activity is the MRI scan. So this is with 451 patients, and they followed these patients over time, and they've identified a number of factors that are very important for having a first clinical attack. And this is, individuals followed up for about 4.5 years. Their average age was 37 when they started. About a third, as I noted, had converted over a 5-year period of time. But not everybody's the same. Individuals had spinal cord involvement, much more likely to convert. People under the age of 37, a little bit more likely to convert. Men versus women, men much more likely to convert. If you have all three of those factors, your likelihood of having a clinical attack in a relatively short period of time is dramatically higher than someone who has no risk factors. So these are clinical factors that we know are potentially risks for developing clinical disease in someone who's never had clinical disease. In addition, this is a study that was published a couple years ago, again, by Dr. Lebrun, and pregnancy itself may be a risk factor for developing a conversion. They looked at a total of 60 women, and it was a significantly shorter time for conversion to the first neurological event in the people who got pregnant compared to those who did not. So although we think of pregnancy as protective for MS, in this particular study, something about the hormonal changes in the hormonal milieu perhaps altered their risk of having a first clinical attack. So those are all a variety of clinical factors, radiologic factors that might be relevant. And we know from a variety of different studies for the development of MS that smoking is a risk factor, obesity, vitamin D levels, Epstein-Barr, et cetera. Over 200 genes have been linked to potential risk of developing MS, the greatest of which is HLA-DRB1-1501 here, which confers about a 3 to 3.5-fold increased risk of developing MS. But are there other markers of risk of MS, especially for those with some very preclinical or early clinical signs? Are there other things that we might be able to look at in the blood and the spinal fluid that are potential risks for developing clinical symptomatology and perhaps would help us define those who might have a very benign course with MS compared to those who might have a more significant course with MS? And a variety of things have been looked at, and it's not important to remember what all these different factors are. It's only important to know that in both the blood and the spinal fluid, a variety of different inflammatory markers are being looked at that may be relevant to how people go with the course of their disease. This is one that's chitinase 3-like 1. That's one of my favorite words in all of the stuff we do. I have no idea what that means. But it's a generalized inflammatory marker, both in blood and also in the spinal fluid. And this is controls, radiologic isolated syndrome, clinically isolated syndrome, and people have already fulfilled diagnostic criteria for relapsing MS. And you can see that there's a higher amount of this inflammatory marker in the spinal fluid, although with quite a bit of overlap between them. So maybe not useful as a distinctive marker. You'd like to have the controls down here and then, up higher, a clear distinguishing mark for those who have whatever condition. But surely showing at least that there's an elevation over time. And in the same study, the individuals who had a low chitinase level compared to those who had a high chitinase level were more likely to fulfill diagnostic criteria, both the old criteria Poser as well as McDonald criteria, the newer criteria, and their time to disability was also faster. So perhaps a high level being predictive of having disability over time. In another study, with 75 RIS patients, those who converted to clinically isolated syndrome or those who converted to a full diagnosis of MS. In the bold here, you can see that the chitinase was not particularly predictive in this particular study. None of these were significantly different. But other markers were. The old-fashioned oligoclonal bands were arguably the best marker, and a number of studies have shown in radiologic isolated syndrome and clinically isolated syndrome that having oligoclonal bands does predict early new disease activity. But another marker here, neurofilament light, not the National Football League, but neurofilament light was shown also to be significantly if there's an elevation, this is in spinal fluid, that there's a risk for developing a first clinical attack or full risk of developing MS. And a variety of other factors were looked at, and actually none of these were particularly predictive in this particular study, although it's shown you in other studies that perhaps sex was predictive, and we know that T2 lesions on the brain scan are predictive, and perhaps age. So some discontinuity between the studies, but notably the biggest risk, the biggest hazard ratio was for the old-fashioned oligoclonal bands. And similarly, this is just a way of showing that in graph appearance, the chitinase didn't really show any difference with high and low levels, and this high and low levels in neurofilament light, however, was predictive, and those were more likely to go on to have clinical disease, and then the oligoclonal bands showed the biggest difference. So again, looking at markers that will help us to define who's at risk of having clinical disease, and this is in the spinal fluid. Similarly, this is a study in clinically isolated syndrome showing that neurofilament light is elevated compared to in those who converted to clinically definite MS compared to those who did not and just stayed at clinically isolated syndrome, again, in the spinal fluid. But what about, we'd like to know, does this have an impact on other things over time? And looking at the bottom here, the brain parenchymal fraction, BPF, or percentage brain volume change over time. Individuals, this is over 5 years on the bottom here. Individuals who had the highest amount of NFL in their CSF were much more likely to have the greatest volume loss in their brain. These are negative values here going down. So that high neurofilament light is a marker when it's in your blood or in spinal fluid, suggests that there's been damage to the neurons, the axons, the cables that connect the nerves one to another. And so this is consistent with the idea that early damage to the nerve cells are associated with brain volume loss over a 5-year period of time. Now, this is not a marker that is specific to MS. This is being studied in head trauma. It's being studied in Alzheimer's and a variety of other conditions. But it is a marker of activity against the nerves. And again, reinforcing Dr. Vollmer's note from earlier that although the myelin is important, the nerves are probably more important. And what about serum, though? Serum neurofilament light. Can we actually have sensitivity so we don't have to do a spinal tap? And the fact is we probably can. So this is, again, looking at people with CIS, early MS, not yet, but fast converters and low converters. That's people who are slower or faster to have another clinical attack compared to controls. Not particularly different from one another, but both greater than healthy controls. But most importantly, this is in the serum. And so the new technologies allow us to measure this in blood, not in spinal fluid. Well, you can still do it in spinal fluid, but you don't need to use spinal fluid. And this particular study with neurofilament light, a number of things correlate with neurofilament light, such as T2 lesions on the brain scan, gadolinium or active lesions, disability, all correlate with the NFL levels. Notably, interestingly, the oligoclonal bands did not correlate with NFL levels in this particular study. But in serum, you can see correlations with things that we know have impacts later in time. And what about looking at specific markers that are relatively coming from different cells? And you heard Dr. Vollmer talk about the B lymphocytes, and I only want you to look at one thing on this table here. Production of cytokines, the hormone-like molecules that are emitted by white blood cells and are communicating between different white cells and are even potentially causing damage themselves in the nervous system and other organs. It is interesting to note that those who convert early from clinically isolated syndrome into, or from radiologic isolated syndrome into clinically isolated syndrome, have a drop in the production of one anti-inflammatory cytokine, IL-10, specifically coming out of those B cells. So one particular molecule inside of these white blood cells may drop prior to having new clinical disease activity. That would be extremely helpful to know if this is shown by others as well. So all of this leads to a study that we're doing, and if anybody's interested, Nicola and Ian in the back would be happy to speak with you. And this is looking for risk factors in early MS or rise MS, looking at these kinds of things we've been talking about, but looking at it in individuals who are at the highest risk of developing MS. That is, individuals who have first-degree relatives with MS, either their parents or a sibling. And so the concept is that those individuals have a 10 to 20-fold increased risk of MS, and the study will be to look at up to 300 individuals who are asymptomatic from 18 to 30, that is before the typical onset of MS, which mean is about 30, and look at a variety of different environmental aspects, activity levels, smoking, et cetera. Look at a variety of different known blood factors, look at the immunological factors, neural damage NFL markers, activity monitors, do a brief screening MRI scan, and look at those individuals who have abnormalities that look like early MS, even though they're asymptomatic, and those who do not, and then compare all these other different factors to see what might be predictive of those who've had changes on their scan. This is very similar to another study called GEMS, Genes and Environment in MS, that I'm going to skip over because I'm late. And the importance of this is that early recognition, treating before symptoms, may be important. We now know that there's a study in radiologic isolated syndrome, again run by Dr. Akuta, looking at dimethyl fumarate, Tecfidera versus placebo, and that's underway right now. We know that just yesterday, that in children with MS, the FDA approved the use of fingolimod, Gilenya, the first drug approved for the treatment of pediatric multiple sclerosis, which is a major milestone. And it showed direct, very significant benefits compared to not to placebo, but to Avonex, interferon beta-1a. So to an active comparator showed substantial benefits in addition to that. So this is a major milestone. 5% of people are diagnosed with MS prior to age 18, and they now have an FDA-approved therapy as of yesterday. The other aspect of this is that they also allow for the creation of a risk algorithm. Can we identify modifiable risk factors very early in those who appear to have risks and create a monitoring algorithm? And if we ID and follow participants long term, can we determine those factors that might be able to distinguish severe MS compared to benign MS? Can we come up with very early markers that help us decide which paths one may take that may fundamentally really alter the way they get treated over their lifetime? So this is also another potential outcome from this study. So thank you very much for your attention. We appreciate you coming out today, and I hope you've all learned something.
Great. Thank you so much, Dr. Corboy. And as Dr. Corboy mentioned, Nicola will be out in the lobby at the research table. So if you are interested in participating in the RISE MS research that Dr. Corboy discussed, please do visit Nicola and talk with her more about that. With that, I would like to introduce Dr. Robert Gross. Dr. Gross divides his time between patient care, teaching, and clinical research. His research interests include the identification of biomarkers associated with treatment response in MS and the establishment of prospective databases to aid in prognostication. He'll be talking today about some of the common misconceptions that are floating around there about MS. So with that, I'd like to welcome Dr. Robert Gross.
Hello. Is it on? Can people hear me? No.
That button?
Yeah, I thought I hit the button.
Yeah.
Oh. How about now? Nope. Go ahead.
I just had it. Very good.
Good. Oh, yes. Now you can hear me, right? In the back? Everybody? Good. Let me get this pointer. Very good. Well, thank you for staying for my talk, which is misconceptions in MS. Misconception number one, MS is a demyelinating disease. So most of you probably were here from the beginning, and you've already heard now that MS is not a demyelinating disease. But just try to remember what you thought about MS yesterday. Now, show of hands, how many people thought it was a demyelinating disease? Yeah, that really, everybody's hand should go up, right? Because that's what we were taught. Everybody, throughout from the very beginning of what we knew about MS, we thought that it was a demyelinating disease. Myelin is that fatty substance that surrounds the nerve projection, the axon, and it helps it conduct its signal better. And we know that people with MS, the brains of people with MS, if you look at it under a microscope and apply a special stain, you'll see that the myelin has been lost. So that's why we think of it as a demyelinating disease. But we know that it's more than just myelin. If you look at it under a microscope, you see all of those inflammatory cells and proteins that you heard about earlier from Dr. Vollmer. And that inflammation, we know as the disease progresses, becomes more widespread. And here, I think a picture is worth 1,000 words. You can see on the left is the usual MRI, the flare-based sequence that we tend to show you when you come into the office. And hopefully that seems like it's projecting. Is that projecting good? Okay. So, top button. Top button. Yeah, there we go. Okay, so So you see here, you've got these bright spots, and these are your typical MS lesions, and here they tend to be kind of coming out of this central area, the ventricles. And the flare sequence is helpful because from the very first sign of inflammation in MS, as you heard about with Dr. Corboy, you get these bright signal on the MRI. And then over time, those signals, that it stays there, but it's not necessarily the same inflammation. It basically gives you a running tally of all the insults that your brain has had over time. And in there you can see actually you can't see, but there are lesions there that have been demyelinated, some of which have been remyelinated to varying degrees. But on this sequence, which you might not see as often, which is a T1-based sequence, you can see there are these little dark areas here right around the ventricles, which correspond to some, but not all of these plaques that you saw in the flare sequence. And these are what we refer to as T1 hypointensities, or black holes. And there, it's really a visual representation of loss of brain tissue, and specifically those axon projections that the myelin is covering. And so we care about the myelin, but really we care a whole lot more about what's underlying the myelin, the axon projections, and those nerve cells that the axons are attached to. Next. And brain atrophy, of course, is something that you've already heard about now from Dr. Corboy and from Dr. Vollmer. And this is an increasingly important thing that we're looking at, not just in clinical trials and studies, but we're now more able to look at in the actual clinic. And of course, our goal is we're going to try to reduce the rate of atrophy. We can't completely eliminate it because, as you heard, there's atrophy related to aging. But if we could get that rate of atrophy down to kind of what we see in the non-MS population, then that would be great. And we think that a lot of loss of brain tissue we think that marker, more than anything else, even more than the lesions that you see here, is correlated with advancing disability in MS. So if we could get that down to a kind of a more normal rate, then that would be ideal. And I think it's really important to bear in mind, especially when we're talking about potential reparative therapies in MS, that promoting remyelination is great. Certainly that's a laudable goal. But we also, if it's just myelin, that's not gonna do anything when the tissue has been lost. So reparative therapies to really work in everybody, we're gonna have to have ones that promote remyelination, but also eventually ones that will be able to grow back that tissue. Or prevent them from being, that's kind of more neuroprotection, preventing them from being lost in the first place, which is probably the easier way to go. Misconception number 2, MS is more common in Colorado. How many people think that? Yeah, so when I moved here to Colorado about a year and a half ago, lots of people came up to me and said, MS is more common in Colorado, so that must be why you moved here, because MS is more common in Colorado. And it was just kind of taken as this, accepted truth that, yeah, so of course. And so I looked into it, and I couldn't really find any great evidence that said that. When a lot of what we know about the prevalence of MS comes from some older studies, older epidemiologic studies, and they're not necessarily comprehensive. And in those studies, you saw that Colorado was kind of in the middle in terms of where on the lower end you saw the southern United States, and kind of on the higher end the northern United States. And so that kind of corresponds to what we know about in terms of the distribution of MS from many studies. Still on, right? No. Did it turn off? No.
We're getting a little feedback, so I'm
Feedback.
playing
Okay.
with the volume
Okay.
to
All right, good.
stop the feedback.
Okay. Which is that we know that there is a correlation between the latitude and the risk of developing MS. And that, more specifically, people who live farther away from the equator, either more north in the northern hemisphere and more south in the southern hemisphere, are more at risk for getting MS. And so I think my suspicion was that maybe people were kind of mistaking latitude and altitude. There hasn't been a clear, and we know Colorado has a lot of altitude, but there hasn't been a clear correlation between altitude and risk of getting MS. Now, some people with MS have told me, when I go up high, I feel worse. Well, I don't have MS, but I feel worse also when I go to altitude. So that's kind of a little shakier, but the latitude thing is real. And we heard about kind of more broadly across the country what the rates are based on more recent studies, or much higher than when we had previously thought. The previous number being about 400,000, which would have put the prevalence about 1 in 750 risk of getting MS. But now that we have it, well, soon to be published, hopefully, over 900,000, then that would even make the risk of getting MS to something like 1 in 360, which is way higher than we previously thought. In Colorado, we don't know exactly. The problem is, so I can count the number of people who came to UCH in the past year and had a diagnosis of multiple sclerosis. In fact, I did that yesterday. And you want to know the number? It was 8,900 over the past year with a diagnosis of MS in their chart came to UCH at some point. Now, we're not just seeing people who live in Colorado, we see people who live in surrounding states also. But that 8,900 number sounded about right. I mean, it was recorded. So, and I was at the MS walk the other day, and I heard from somebody that in the Colorado-Wyoming region, there was about 14,000 people living with MS. I'm not sure where they got that number. That seems a little high. But I think the point is that we don't have an accurate head count, because MS is not like one of those infectious diseases that have to, when you diagnose it, you have to report it to public health officials. You don't have to report MS. And so it can be very challenging for some of these studies about who gets MS to actually get an accurate number, right? And some of that might also have to do with the fact that you can have MS and not yet be diagnosed with it. You can have had MS for many years and you just don't go to the doctor anymore, and so people aren't considering you in those tallies. And so there's a variety of challenges to getting an accurate number. Excuse me, but hopefully we will have some more accurate numbers soon with the publication of these new data. And then if it indeed is a higher number, then it would be important to know, well, is that people who've been living in Colorado their whole life? Is that people who, like me, recently moved to Colorado? Because that obviously that says different things about whether that's a risk for living in Colorado or not. And the population of Colorado has grown exponentially over the past 10, 20 years. It was, I think, since 1990, an increase of about 66%. Which is huge. The population, according to Wiki, in Colorado is about 5.5 million. And so if you took that number that I said about people coming to UCH with MS, and you divided that by 5.5 million, then you would get about 1 in 600 something people in Colorado with MS. Of course, again, not just people living in Colorado come to see us. So that would even seem to be lower than the national average, which if you took the 900, so let's say 900,000 people living in MS divided by 325 million people in the United States, that would be about 1 in 360. So it's considerably less than that average. So I think, again, we need kind of some more accurate numbers, and then we need to see if it indeed is elevated related to the whole of the United States, then why would that be? Here's a one that I get a lot. My mom had MS and became really disabled. I'm scared it will happen to me too. Right? And it's a completely reasonable thing to be concerned about. I think first of all, we know that I will reassure people that even within families, not only is some it's not a completely genetic disorder, so it's not like 100% of your relatives will end up, your offspring will end up with MS, but not just the risk of getting MS, but the course within that. If you do get MS, it can be highly variable even within families. And so some people can have more severe cases and other people can have less severe cases. But I think probably the bigger factor in this is that your mom probably was diagnosed and lived for much of the time in the era before we had our current treatments with MS. And our current treatments are very effective in general, particularly when they're started early on in the disease course. And so even if she did end up on one of these treatments, it might have been 20, 30, 40 years after her initial symptoms. And we know that they're most effective when they're started early on. And so I think that might be playing a big role in terms of why we might see the prior generations of having more severe disease than what I think we can achieve now. And then just another plug for Rise MS that you just heard about from Dr. Corley. So it seems like it's pretty painless. So if you guys want to, when you're hanging out with your family at 4th of July or Memorial Day, if you just want to kind of, hey, what do you think about coming into UCH and getting don't people want to see what their brains look like? I think that's kind of interesting. And so, I don't know, just another plug there. Here's one. I don't need medication. I'll just change my diet. Yeah. So, no. Let me back up. So, if that is your diet, then yes, perhaps you should be changing your diet. In fact, I tell everybody who with MS or without MS that they should be trying to follow a healthy diet. I mean, that makes sense. But when it comes to MS, we know from years of not having any disease-modifying therapies that if you just try to do it based on diet, it's not going to go well. And so if your doctor says, I think you need to be on treatment for MS, then independent of what you decide to do with your diet, that means you should be on treatment for your MS. Yeah, I was actually just in the office yesterday. There was a young woman who came in, and we last saw her in 2015, so a few years ago. At that point, recommendation was made to go on treatment, and she said, well, I'll think about it, but in the end opted to not be treated and said, I just kind of want to do the healthy, the natural way. And then she comes back to see me, and she is worse, unfortunately. So, it's very hard to see stuff like that because that it can be prevented. It really can. And there is a role for changing diet, certainly, because we know that people who live healthier lifestyles, as you heard from Dr. Corboy, who tend to eat well and exercise and have fewer other medical problems, they tend to just kind of do better, even do better with MS. And so that is an important part of things, but it shouldn't be done at the exclusion of treatment if your doctor thinks you should be on treatment. And so thinking just about kind of, if you were going to try to design a study of diet in MS, these things have been challenging to do for a number of reasons. One is, unlike, say, I want to do a trial of, ocrelizumab or Gilenya or whatever, there you can randomize, you can get a large group of people, you can split them up, you can randomize them, you give half the group the medication, the other half you give placebo. With diet trials, it is harder because it's not just a pill and then anything else can be whatever the person wants to do. It's really everything that person puts in their mouth, and so you have to really it has to be standardized that way. And in reality, people are going to not follow it, and they're going to eat what they want to eat, even if they were randomized to a certain study. So I saw a study a few years ago that randomized people with MS to like 1,000 calories a day diet. That would be really hard to do for me. I can't even do that for a day. I mean, I can't imagine trying to make somebody else do that for months at a time. So I think that's some of the inherent problems in that. And then even if you do a couple month study that shows that this diet seems to be more effective than this other diet, which again, that's a big if, then there's always the question about generalizability and how much that you'll be able to, say, well, this is representative of everybody with MS, that everybody with MS should go on this diet. So these are unanswered questions, and I take a lot of I get a lot of questions from my patients about diet, and it's what do you think about this diet? What do you think about that diet? And before I see, until I can see really large, well-controlled studies involving that diet and on real endpoints in MS, I remain skeptical, is I guess the best way of saying it. There is some interesting work, though, being done. So the diet is, of course, one smaller part of kind of just the overall ecosystem and what goes on in a person's gut. And your gut is one of the main ways that your body has of communicating with the outside world. And one of the major ways that your immune system has of being educated about the outside world. And so there's almost certainly a relationship there between the development of diseases, particularly autoimmune diseases, and what's happening with the diet. I'm convinced that there probably is a relationship there. But what is exactly that relationship? You have billions and billions of different microorganisms living in your gut. There have been a lot of kind of smaller studies looking at a handful of patients with MS and a handful of patients without MS, and what are the different species of organisms living in the gut. And they show some differences here and there, but it's unclear whether those differences are just there by chance because you have billions and billions of different organisms. Of course, they're going to differ in certain ways between people, but it's not clear whether any of those differences is causal. And then, even if it were, how would certain changes that you might make to your diet or changes related to medications that you're taking, how would that affect that ecosystem and thereby contribute to hopefully improving your disease? That's all of those things are big questions that we don't have good answers to yet. Here's one. I heard marijuana or LDN helps my MS. LDN is low-dose naltrexone. I put this on the same slide, but I'll address them individually. So first, marijuana. Some of you might be surprised to learn that marijuana is legal in the state of Colorado. In the country at large, still, though not, which has made studying it kind of problematic. So we can't really do the kinds of interventional trials that we would normally do with other medications. But I think a good question to ask is, well, what is marijuana? I mean, the answer is it's not just one thing. It's hundreds of different chemicals there, so which would make studying of it even more challenging because you unlike, say, again, gileniant or ocrelizumab, those are one thing, right? Whereas if you're studying 200 different things, it's really hard to know if there is an effect, what the effect is coming from. You understand what I'm saying? And then even kind of standardizing that, say you wanted to do a trial, you would have to make sure that you got the exact same plant with the exact same ratios of this ingredient to that ingredient to this ingredient. Otherwise, you're giving people just different things. And so it's really hard to know what would be, what to conclude from all that. We have asked you, so I learn a lot from talking to my patients and having them tell me what they experience when they try different things. And so we have asked you what you thought of when you try, and many of you have responded in our surveys, and it turns out about 38% of you have tried marijuana, and some people have found it helpful. That's I think within the past year, maybe more probably in their whole life. But some of you have found it helpful for certain things. Some of you have not found it as helpful. I think that's one step in kind of knowing what it can potentially do. I think it's also important, and that's kind of part of the reason why we do clinical trials, is we need to know what are the safety concerns. And we know that with MS, we have to, with marijuana, we have these concerns of, slowing reaction time, potentially limiting attention and concentration and that kind of thing in memory. And these are things that can already be affected in MS, and so you could potentially be compounding any impairment that you might already have from MS. So that's very important to keep in mind. The LDN, before, I know I'm running low on time, so LDN, low-dose naltrexone. So naltrexone is, it's a medicine that's available, FDA approved, to treat opiate addiction. What it does is it blocks the opiate receptor. And then it's been hypothesized that if you give low doses of it, that it might have some anti-inflammatory effects. Now, it kind of, again, going back to this earlier point, which is that, until you see large, well-controlled studies that have looked at this and clearly shown that it's effective, I remain skeptical specifically about claims like, it's reducing inflammation or what have you. Now, there have been a couple studies a few years back, smaller studies, short studies, that have looked at this and randomized people, and it looked like in one of the studies, the LDN seemed to go along with some higher quality of life measures, but in the other study, it didn't really seem to show that. So certainly more work needs to be done in this area to know just how helpful or not, and certainly what kinds of side effects there might be in the long run. My blank hurts, it must be my MS. So you may be surprised to hear that people with MS are actually just normal people who also have MS, and we know that normal people can have other ailments, from heart problems, lung problems, GI problems, you name it. You can get any one of those things if you have MS. And so if you have a new symptom, it's not necessarily the case that new symptom is related to MS. It might be, or it might not be. But I think the important thing is, if you're not sure, or if you, in any case, you should probably talk to your neurologist, and your neurologist may decide that you need to see another specialist to get more fully evaluated. Don't worry if that happens. It does happen frequently. And I think this is my last slide. My MRI is stable. Why am I getting worse? Now, this is really kind of goes to the heart of a lot of what we think about with MS and with why people get worse with MS. So first of all, we know that there's this discrepancy between what we see on the MRI, particularly those flare sequences that you saw on the earlier slide on the left, and what kind of symptoms a person has. So, for instance, Dr. Corboy showed you those slides. One person had radiologically isolated syndrome, didn't even have any symptoms. The other person had MS and probably had attacks of this, that, or the other, and those MRIs look the exact same. And so So MRIs are helpful, but they can't really tell you how exactly what the person's symptoms are, particularly MRIs of the brain. And so, one thing to know is if you are thinking that things are getting worse for you and the MRI is saying that it's stable, is it the MRI of the brain that's stable, or is it the MRI of the spine that's stable? Oftentimes, we just, in routine clinical care, we'll just do MRIs of the brain. We might not check the spine. And so it might be worth also looking at the spine to see, is there more disease activity in the spine now that might be accounting for your symptoms? And then there's this concept of pseudo-relapse. We know that symptoms can fluctuate in MS, and that some people, when their body temperature goes up, when they get an infection, when they're under a great deal of stress, the symptoms that they had previously had that had resolved kind of now come back out into the forefront. And that should go away whenever that external stressor or what have you is removed. And so that we don't think of in the same context as new inflammation per se, because say changing immunotherapies is not necessarily going to prevent these pseudo relapses from happening. And then of course we have progression, which is oftentimes when we see it, this little by little worsening over time in the clinic. It's not associated with new changes on your MRI. Oftentimes we don't see any new T2 lesions, GAD-enhancing lesions, but the person is getting worse over time. And so that has to do with the fact that we don't have great MRI tools at the present to kind of correlate between why a person's getting worse and that from progression in MS. And brain atrophy is going to be a part of that. and being able to measure that more accurately, more reproducibly. So I'm out of time, so I'm finishing up here and just wanting to talk a little bit about brain reserve. So we heard a little bit about this before, and I think it's an important emerging concept in MS, and it's that idea that people can have more, maybe brain volume, but something that will allow people to weather the changes in MS more than other people can. And so even if we have atrophy, even if we have new lesions, what have you, some people are going to feel it more than other people are going to feel it. So some of that variability, some of that heterogeneity is probably related to how much innate reserve in the brain that person has. That's it. Okay, good.
Excellent. Thank you very much, Dr. Gross. Very interesting. I would like to, before we break, I would like to take an opportunity to let you know about the MS Center's volunteering opportunities. We have lots of great ways for you to volunteer with us throughout the year if you're interested. We have our hydrotherapy program, our MS Young Professionals Network, our Adult Day program, and then special events that we host throughout the year that we always love volunteer help with. So it's a great way to get involved with our organization. If you're interested, Sarah Kiger is our volunteer manager, and she'd be happy to talk with you more about that when we break, and she'll be circulating in the lobby. And I would also like to take a moment to thank Kelsey Lance. She is our education coordinator and did a great job putting together today's event. Thank you. So with that, let's take our break, and then we'll reconvene for our final 2 sessions. So please do be sure to fill out those note cards. And then we'll come back for the door prize drawing and Dr. Hebert's presentation and our Q&A panel. So thank you. We'll get started here in the next couple of minutes, so if you want to make your way to your seats, that would be wonderful. Thank you. If everyone can make their way to their seats, we'll get started shortly. Thank you. Okay, thanks everybody. Welcome back from the break. And actually, we're going to kick off this section of the program with a little drawing for this fun door prize. So thanks for everyone for getting your tickets in. So I'm going to draw the ticket now. Get your tickets ready. So the winning number is 269933.
Bingo.
Anyone?
See everybody, they're like, what?
Do we have a winner over there? The number is 269933.
Do you have to be present to win?
Well, I'm going to draw another one, I think. 269922. Any winner? Oh boy. One more. 269949. Oh. You do? Oh, excellent. We have a winner. Yay. Sydney. Excellent. Congratulations. With that, I would like to introduce Dr. Jeffrey Hebert to the stage, and this is our final presentation for the day before the Q&A session. Dr. Hebert is a physical therapist by training with extensive education and experience related to treating MS patients. His clinical and research expertise includes examining, treating, and investigating balance, fall risk, mobility, fatigue, and other related symptomatic outcomes. Today, he'll be talking with us about balance issues in MS. So please join me in welcoming Dr. Hebert.
Thank you. Thank you, Carrie, and everybody else that have organized once again a fabulous summit for us today. And as well, all of you for sticking this out for the entire morning, so I really appreciate that. So just a little bit more background on myself. So Dr. Corboy and I have been working for the effort in the MS Center for 20 years. So we've been working together, and I'm going to present today some statistics that are correlational and association. So it's going to be one variable goes up, the other one goes up, and that's a direct correlation. So I'm proud to say that I think I have the years I've worked with Dr. Corboy correlate directly to the amount of gray hair he has on his head. And then Dr. Vollmer, for the over decade, it's an inverse relationship. Number of years, lack of hair on the head. So that's just the way I am and what I bring to the center. So thank you all again, and happy Mother's Day to everybody. Okay, so my disclosures are very minimal. The only biggest disclosure, and obviously nothing related to this talk, but there's one big disclosure I have to have, is one thing is I'm very passionate about what I talk about and what I do. So that's the biggest thing. I got a big bias about that. Okay, so what are we going to talk about? So living an active lifestyle is one. The importance of that, sometimes that's played off as exercise, but there's also the concept of being physically active. So exercise gets a bad rap. It's like the four-letter word as far as it goes with MS. But we're going to bring this to the table today of the importance of overall of exercise. And then balance and fatigue is going to be a secondary concept of the talk today of what we've built in a foundational work in order for us to go to the next step of building an actual treatment plan that goes after some of the barriers that might stand in your way to adapt to or adopt a more physically active lifestyle. So exercise in MS. So it has only been about 20 years, almost to the year, that a seminal article came out that reported that exercise is possible for persons with MS and it's beneficial. So possible means that there's not a lot of side effects and it's not of harm, because prior to 20 years ago, exercise in MS was don't do it. You're going to get too fatigued and you're going to hurt yourself. Okay, so then 20 years ago, an article comes out, says exercise is possible. Since that time, there has been a swell of research, and thankfully, here at the Rocky Mountain MS Center, we have been a large part of that as far as building that concept that exercise, and Dr. Vollmer and myself and a large colleague, co-authors, authored a paper a few years ago of the importance of possibly exercise as a prescriptive component to exercise, to MS, and that it should be almost like a line item on that old form of writing out a script. So it's very, very important for persons with MS, and obviously that left-handed column is the possible potential benefits, and a long list. Some of that is fatigue, improving strength, improving endurance. The center one, the center component, is it's still out there. There's a lot of animal research is where it starts from. And this is where we start to talk about exercise being possibly neuroprotective. But there's a long list of very technical terms there. And one that's really striking is neurogenesis. So neurogenesis is actually the concept of growing or building new nerve cells. So that's a very, we're at the doorstep of trying to see if that's really possible in humans, which there's been some early studies that have shown correlations to that, and I'll share one with that today. And then also, is it possible in a neurological condition, in autoimmune disease, is it possible to actually grow or have your brain be more plastic and actually become more healthy with exercise? And I'm here to say it's very possible. So Dr. White is really, back in the 2008 era, is saying, yeah, maybe even the immune process can be benefited through exercise. And then the bottom line really is, that's all fine and good, but what about that bottom line indicator of, it doesn't really improve my quality of life? It's one thing to be able to get on a machine and exercise for 30 minutes, or lift a pound of weight, about 10 pounds, but what does that really do for your quality of life? So it's not just doing exercise just for the sake of doing it, because you've heard it might be good, but is it going to improve a lot of aspects of quality of life? So this is an article that I share. I was quickly putting this in because I want to thank my colleagues for fantastic presentations today as well. And I like to go last because then I can see what's been done before. So Dr. Corboy, presented this kind of like downhill slope of the brain volume, which is, that's a normal aging process. And I see MS and a lot of the neurodegenerative diseases of the brain and the spinal cord as being an accelerated process of aging. So you're just putting the accelerator down a little bit faster on the aging process of the brain. So there's one thing that you can do about that, and it takes active participation in activity, physical activity. So this is in healthy subjects. So non-MS, this study shows, again, I was going to tell you, I'm going to do correlations. So one variable goes up. Physical activity, the amount of activity, minutes per week, correlates directly to brain volume. In an area of the hippocampus, a really small area in the brain, but very, very important concepts of cognition. So it's really a big target about how healthy is your brain. If your brain's bigger, it's going to be more healthier in general. And that's what we've been really in the clinic, in the studies, looking at what's your brain volume over time. How can we protect that loss of brain volume? And here's one that says in healthy subjects, it's very possible. We're not there yet. We haven't had a great study that's shown that in MS, but there was a nice one in MS that showed the importance of exercise in the trajectory upward with increased exercise, both in water and land, showed an upward trajectory of increased serum in the blood of an important growth factor for the brain. So the way that our brains are healthier with exercise, you've heard of hormone release like endorphins, like, oh, I get that runner's high. It makes me feel good about myself. That's one type of hormone. There's one really important hormone that is involved in growth. And I term it as like the fertilizer for the brain. So if you're engaged in social activities, work, still employed, problem solving, oh, my plumbing went out in the house. Instead of outsourcing it, can you go get a book and learn how to do your plumbing? Keeping that brain engaged along with exercise is a great marriage, because with that neurotrophic factors, that's a fancy name for the hormones that are released in the serum with exercise, and of course the brain utilizes blood, it then can be that fertilizer that allows the brain to enhance maybe the neurogenesis, neuroprotective agents of exercise. So that's my shout out for exercise. So I added those last two in there because I do a lot of talks, and I was like, oh, I got to add that in. So I added those two in, so it's not on your handouts. So physical activity, really important. However, I always say, you lead with person with MS. You're human. You are people. And as our nature is to be more inactive. So I could give this same talk from here on out about exercise and the importance of exercise for persons with MS, without MS, healthy, young, old. Exercise is important. But by nature, nationally, internationally, we are inactive. And for persons with MS, more sedentary, more physically inactive, of course. So barriers to engage. So there are plenty, but there's been some articles out there that have shown for sure, fatigue, pain, depression, mobility. If you have mobility limitations, it's hard to engage. And how do I run anymore? How do I walk anymore? Well, if you can move a limb anywhere, that's exercise. That's physical activity. If you're wheelchair bound, you can still exercise. If you're still running a marathon, still run it, but let's make sure you're doing it the right way. But the two big barriers to that are fatigue and balance. Those are the two mains that we're going to focus on here on out. So I don't think I really need to go through this because, everybody knows that balance at some given point, the ability to hold yourself upright throughout your entire day, throughout the entire week, month, and year, without losing your balance at some given point, or you adjust the way that you do things. You don't move as quickly anymore. You don't turn as quickly anymore. You start to close in your physical activity, and before you know it, you're not getting out. You're not getting out to activities that you really, really enjoy. really would like to go to that concert, but there's no way I can stand that long because of endurance and/or I just can't balance that long. So that's kind of a no-brainer. Fatigue, number one, absolutely number one complaint for persons with MS. That's well known for well over several decades. But the correlation between, fatigue and balance, prior to a research study that I'm going to show you that we did, there was really it was like they lived in two different worlds in a person with MS. It was like, here's a complaint of fatigue, here's a complaint of balance, and they never really combined them and seen what was the combination there. Just a shout out to other aspects that are important for balance is eye movements and visual fixation. A lot of you might be at some given time previously or in the future might complain of double vision or inability to really focus in and hone in and really lock in on things visually. And that can be very visually disturbance, but also it can directly affect some of your awareness of where you are in space. That's about balance as well. And then another manifestation complaint that's similar to fatigue. Fatigue is more like this subjective report of I'm feeling more lethargy. Dizziness comes out of that as well. And today we'll focus more on the concept of vertigo, which is the spinning, which is, yeah, I know darn well I'm spinning. But the other dizziness are out there too, like pre-syncope, meaning you might be lightheaded and pass out. That's a dizziness as well. But also the unstableness. It's directly related to your place in space, where you feel grounded on this earth. So 3 main sensory inputs are essential for awareness of space, where you are in space as a human being. Vision. We all know if you close your eyes, you're in the shower trying to do your hair, you might be having an elbow on the wall of the shower, or it's like, I think I'm going to wait maybe another 3 days before I wash my hair, or I'll do it in the sink or something like that. But in the shower, standing up, that's very tough. And that's one of the questions I ask my patients. I say, do you have a problem with showering your hair in the shower and closing your eyes? Oh, yes. And then vestibular. Vestibular is your gyroscope. So you have the hearing part of the ears, which is external, and then we have the inner ears. The inner ears are the vestibular system. They're not for hearing, but they are for you to register where you are in space in many different aspects. So you have 3 degrees of orientation on one side, 3 degrees on the other. Add that up, 6 degrees of orientation where you are in space if both of those organs are working well. Essential for where you are in space. Somatosensory, fancy name for can I feel the ground? What am I on? Oh, I'm on a slope. I'm trying to go up the trail and this slope is not working for me because I can't then use my other 2 systems. So what happens is that persons with MS have what's called difficulties with reweighting the sensory inputs. And this vestibular end organ means that it's not part of the central nervous system, not part of the brain or the brain stem, but it's out there. That's the signal. That's the actual inner ear itself. So the end organ, postural control is balance, and then environmental changes. This is you needed to deal with the unexpected, the change in your visual world, the change in your unstable world. It's like, I'm good if I got something stable underneath me. But if not, and it's dark out, or I turn too quickly, that's when things break down. And you move slower. And you become less physically active. You become less fit. So, right there is the end organ. Looks like a dragon or something. But this is your brain, cerebellum and brainstem. And where this comes in is right in the central nervous system. There's 2 parts of the vestibular system. Semicircular canals, which gives you orientation of angular motion of your head. And then the other part is more translational. As you move through here, elevator action. So every movement that you make, whether it be quick turns, head turns, look up, all of that is registered first at the end organ. Signal sends action potentials to the brain in these primary, we call them the central processors of that end organ signal. So in the brainstem and cerebellum, brainstem has the nuclei of the vestibular system, which is the primary processor. The cerebellum is a modulator, so it's a fine tuner. And lesions can be smack dab right in that area where that end organ is sending the signals, trying to get that signal to the brain to do something automatically. A lot of this is reflex. If you have to think about how you move in space all day long, that's where we started to make the connections about 15 years ago of, is there a connection of all of that energy, all of that lack of economy of you being placed in your own space and where you are, that's going to cause a lot of disruption and a big load on your brain, causing possibly fatigue. So I'll zip through this. So posture control, balance, again, those three sensory systems, vision, vestibular, proprioception, and skin, and that's that somatosensory. There's another one too, auditory. Auditory, any sound. So if it's a loud environment, grocery store, certain, like malls or something like that, or celebrations and family, and there's a big party going on, music, that's another thing that the brain has to process. And believe it or not, it comes in the same area that all this other stuff is coming in. And it's like gets in the way. So with the brain trying to reweight what it should be listening to, looking at, feeling, and navigational, that's a big load. If you have a lesion interrupting that, or brain volume, less actual neurons being able to process that, things break down. And so it's a cycle going around and around. The pointer's not even working. So around and around. So barriers. Again, so what we did, Dr. Corboy and I, several years ago, I brought to him, and he looked at me like I had two heads, but then his double vision came in pretty well. And I said, we should probably look at this. Should we look at this fancy machine that we had on campus? So all this has been done at the university here. So this fancy machine, I have a more updated one in my lab on campus, that it's the best way at this given point. It's the grandfather of quantifying your place in space and how well you can utilize the other systems and reweight while you're put through eyes open, eyes closed, eyes open. And that platform that you're standing on is a force plate. So it registers how much you're swaying. At the same time, one of the conditions out of that 6, there's a pivot point at about your ankle that then if you start swaying forward and you only can reference your somatosensory because you're very dependent on that, because you're not listening to the inner ears, and you got your eyes closed, it'll go with you. That's called sway reference. So it doesn't push you or perturbate you. It actually allows you to try to correct it. And in that closet can also move as well. So are you getting vertigo right now just thinking about it? That's the concept. The very things that you would avoid in your natural environment. It's like, whoa, no, I don't want to do that. So there's someone right there doing it. And yes, there's a harness. I don't want you to fall. First of all, for your safety. Second of all, there's a lot of paperwork that goes involved if you fall. Okay, so the study that we did, Dr. Corber and I authored, and we looked at, and that highlighted area this is a questionnaire for fatigue. I'm sure sometime in your life you've taken a questionnaire for fatigue, probably this one, the Modified Fatigue Impact Scale. This is the composite score from this machine. And so those are just the numbers initially. That's fine to report. That's like general characteristics. But then the relationships. So these relationships, a negative is an indirect. Remember, Dr. Vollmer, years with me in reverse. So more fatigue, less balance. And or if you want to think about it, worse balance, increased fatigue. That 0.78 is a pretty large clinical correlation. Very large, meaning they are indirect, almost as if when your balance is worse, your fatigue goes up at the same exponential amount. So then it was interesting because as we publish articles, the reviewers go, okay, jump this high. I want you to do this, this, and this. But it's really cool. They said, what about those different conditions? What about in those different conditions? What did the correlation look as far as when you break it out into eyes open, eyes closed over time? So then we looked at, prior research in clinical screening usually stops at the point of eyes open, eyes closed, on a firm surface, nothing's happening. So there was no correlation there between fatigue and that balance in our study. But when you start looking at when you're starting to challenge the brain to be able to use those sensory inputs, it starts to break down. That's where fatigue correlated the most. So then we went on to establish the BEAMS program. Early on, okay, so just to break this out really quick, so clinically, you'd be working on different surfaces, firm surface, challenging the base support, on compliant surface, additional dynamic, that's a trampoline, believe it or not, dynamic surfaces, rocking bidirectional, adding in the head movements to stimulate, purposely stimulate the vestibular system, to challenge you in being able to say there's conflict there, and on the rocker, and going forward and back. And then adopting a little bit of torsional movement, down in half kneeling, and then multitasking, hand-eye coordination, while you're doing all that on the trampoline, on the foam, not all at once, but in correlation with that. And then additional things on the trampoline, and then movement in space. So it's on command. This is where I get to tell people what to do. So walk forward, walk backwards, turn quickly, stop, eyes closed, feet together, stand on one foot. So challenging you for the unexpected. So we published a 3-arm study that looked at the BEAMS group versus an active control so that we can factor out a little bit of the attention bias. Was it the smoke and mirrors that they just love to come in and work with me? Well, here they came in and worked with me for a different cause, and we compared that against a non-treated control. So these are over 6 weeks' time of supervised training and then 4 weeks of just doing the homework. And during that time, increase of about 18 or 19 in that machine score is a very large clinical meaningful change. These changes right here in the other 2 groups were pretty much just learning effect. And then when they stopped working with supervision, at least the participants were able to maintain with a home program for 1 month. So that's good. Also reduction in fatigue, also reduction in dizziness. So from there, we were able to get a much larger grant to work on a much larger study. This one was published and included Dr. Corboy and Dr. Vollmer and other colleagues on campus, and we published in the largest neurology journal out there. So this was 2 arms, a longer study, because we wanted to see, can we show that maybe with more effort in supervision and coaching, can there be a continued projection past 6 weeks? So same score for the balance machine. After the 6 weeks here, same trajectory that we saw in our previous pilot, but lo and behold, yes, we are able to see a continued and statistically significant difference between not doing the beams and following greater, so we can get more effort. So that kind of supports the fact that, hey, can I go into the clinic a little bit less often, but longer to get an effect in my change in balance, and change in fatigue, and change in dizziness. There were also changes in, positive changes in quality of life, and just a little tinge on self-reported concept of some domains of cognition, but not a cognition test. So be careful about thinking about that. It directly changes cognition. We're not there yet to show that. And then also we looked at parceling out those that had involvement of the brainstem and cerebellum. Remember the processors of all this information for the balance? Is that we looked at, could it be that those individuals might benefit differently or benefit more? And in our ancillary analyses, we did show that for the shorter period of time, they definitely improved to a greater degree. But they also started off with a lower amount of fatigue, lower amount of balance, and increased fatigue and increased dizziness. So the baseline, they start off a little bit lower, so your delta change is possible, bigger. So that makes intuitive sense. But it's one of the first. It's nice to say the concept of, yeah, but I've got lesions in those areas. Now let's not work on it because there's a hindrance there. This is one of the studies that early on says changes can be made even though you have lesions in those areas. So one thing that can happen, this is called vestibular compensation, means that you are changing the ability to have your awareness in space. So in the vestibular rehab world, because the beams is a modified version, an accentuated, multifaceted form of vestibular rehab, that restoration of that orientation in space can happen naturally over time. But you are a person, but you do have involvement in the brain, so it's less often that you're going to have restorative vestibular compensation. That's where adaptation comes in. That's where the beams, we are theorizing that the beams affects a person in possible neuroplastic changes. However, that's hypothesis. That's a working hypothesis, and that would be probably our next stage or stages going forward to see if there's changes in the brain pre and post beams. And then there's habituation, just even creating the white noise. So if I turn my head, I get a little dizzy, let's do it again. Create that white noise. So the brain says, that's okay, I'll get over that. So that's possible too. So neuroplasticity in MS, it's possible, usually early on in the stages when there's less involvement. But the number one thing is that it's hardly ever, the spontaneous reorganization of the brain is never complete. So there's got to be some enhancement. It's possible that such things as the beams could be the training-induced or experience and task-specific training that could create some reorganization so that you can navigate yourself in your world a little bit more, so that you can actually create some regional changes in the brain, possibly. Again, hypotheses. And then I want to just point out that, yes, there's going to be side effects when doing this. Expect when you're working with the beams, the early on, first 2 weeks or so, you're going to experience more symptoms. However, with staying with it, you're going to get the long-term benefits. I always have to tell my patients that. Stages of that compensation, you compensate well, you actually adapt well, but then over time, if you don't continue, because as you continue to live, you need to use this as a maintenance program, the importance of making sure you don't fall backwards. Because exercise and the beams specifically is not your medication prescription like an antibiotic where you take it for 10 days, you're done. It's a long-term medication for you. Exercise is long-term, lifetime. My girls would like to thank you for your time and interest in this topic, and the bottom line is, let's get more quality of life and sustain it. Thank you.
Thank you very much. Thank you very much, Dr. Hebert. Appreciate that. And now we will be concluding today's program with our Q&A panel. So I'd like to welcome all the doctors up to the stage to begin that portion of the program. And be sure to, I think we've collected all of your questions so far, but if you do have any last minute questions, please be sure to raise a hand and we'll come around and collect that from you. So with that, doctors, please join us on the stage. Thank you.
We'll see.
Coming in? Now can you hear? Pete, is it coming through?
Working on it.
All right, well, again, for those of you that haven't submitted a question, if you want to, just write it down, raise your hand, and one of the folks will pick it up and bring it up. So we have a series of questions, and we're going to sort of go through them as best we can.
Volume.
Is this one working now?
Try again.
Can you hear me back there in the back? Okay.
Better.
So to start out, I'm off again.
Maybe it was this one.
All right. Technical problems here. Okay, we'll stick with this one. We'll hand it around. So one of the couple of questions that came up related to the talk that I gave, I'll just run through them so that we have done. One of them had to do is what's the recommended dose of biotin for supporting remyelination? So you can buy biotin over the counter, but the amount of biotin in the capsules is generally less than 1 milligram. The dose that was used in the clinical trials is 300 milligrams. And it's not really possible to buy that over the counter, and you can't take that many tablets without getting in trouble for other reasons related to the materials that the drug is diluted in. So that can be made by a compounding pharmacy, but again, at this point, we don't know for sure that it's helpful. And one of the things you have to keep in mind with biotin is that it interferes with a fair number of blood tests, particularly related to thyroid function. So if you're on large doses of biotin, it's very important to tell your physicians about that because it may give very strange blood test results. Second one was the same thing. What is the recommended dose for alpha lipoic acid? I don't know what the dose is that you can buy over the counter for that, but the dose that was used in the clinical trials was 1,200 milligrams, usually given as 3 times a day dosing of 400 milligrams at each dose. Dealt with that one there too. And then there was a question about what's the over-the-counter name of clemastine. It's clemastine. No, there's daily hiss allergy, and allergy relief. But you'd have to look on the active ingredients list to see. But again, the dose that's in the over-the-counter products is quite low compared to what they're considering for studies. And I don't think at this point that we're at a point where recommending that would be wise given the potential for certain side effects. And then the last one was on cladribine. Question of whether it has an over-the-counter name. It doesn't. Cladribine is not available over the counter. It is a potent chemotherapy, and at this time, as I said, is likely to be approved within the next year, probably the next several months. And it's a treatment that has significant risk associated with it, so you need to discuss that with your neurologist. Okay, so question, when are reparative therapies typically begun during treatment? Right now, we don't have any that we're sure of. So, but this is an ongoing discussion, whether you would use these in relapsed remitting MS or whether you would use them in progressive MS. Certainly progressive MS, there's a lot of unmet need, but there are reasons to think that using them earlier in the disease course may also help improve long-term outcomes. Anybody else have a comment about that?
Yeah, I would just add to that is this working? So I would just add to that as multiple ones of these, multiple of the slides showed, the degenerative component with multiple sclerosis begins early. Even though we think that the inflammatory component is very prominent early and maybe diminished later, which would have a whole nother set of questions we may have about how long would you use the presently available disease-modifying therapies. The reality is that there's a component of dropout of cells, and protecting the cells from dropping out is probably going to be useful from the very outset. But as Dr. Vollmer mentioned, the reality is we don't know yet because studies have not yet been done. So you could envision, though, that you would have studies starting whatever medication, disease-modifying therapy, where you added either placebo or some neuroprotective agent to see if that in fact does better than just the disease-modifying therapy alone in a newly diagnosed population. And I would say that once something is proven to be helpful, it's likely to be helpful for all phases of MS.
Another question for any of you that would like to take it is, why do lesions so love the ventricular areas as opposed to following the arteries and veins or venous sinuses? And does this imply CSF is more toxic than blood?
Saying that one down.
Yeah, sounds like we don't know. I mean, so in MS you get periventricular lesions, but you also get cortical, juxtacortical, subcortical lesions in the back part of the brain and the where the cerebellum, the balance part is. So periventricular lesions are just one part of what we, and spinal cord, of course, that we see in MS. I think some of that probably does have to do with the migration from the spinal fluid system. But we also probably see inflammatory cells coming from blood vessels that is the reason why we see MS lesions in other places as well.
All right, I'll take a stab too. There are probably multiple different pathologies in MS. So the classical so-called white matter lesion, which is so prominently seen in all the textbooks, these are lesions that are wrapped around veins. But at the same time, we know, especially in older patients, that there are also lesions in the lining of the brain, the meninges. And there's an association between seeing these follicles of B lymphocytes and plasma cells, and association with underlying damage. So this is all the way out on the outside of the brain. And there's damage that's associated with that just underneath the surface of the brain in the cortex, so-called gray matter lesions. And the more that you have of these follicles, the more you have gray matter abnormalities. And the lesions that are seen there really don't look anything like what you'd see in a textbook. So this gets at this very broad philosophical argument that remains with regard to what causes MS, the so-called pathogenesis. And is it an inside-out problem? Is it coming through the veins and arteries up into the brain, into the spinal cord, and then somehow going out into the brain? Or is it really more from the outside in, coming from these follicles that are on the outside? The reality is that I'm not sure we're going to be able to make that distinction, or it could actually be both, and it might be different at different times. So it's one of the biggest conundrums, is understanding where does this process actually begin. Once we understand where it begins and what incites it, we'll be way ahead of the game. I mean, in one large sense, it's interesting to note that in Alzheimer's, they feel that they have what are known correlates pathologically of deposition of various molecules. And the hope would be that if you could stop that from happening, that would help the disease process. So in theory, they would have a big leg up on us in MS because we don't really know that. And yet, it's turned out to be the opposite. We have many more therapies that are approved that are known to be effective, even without knowing what the actual target is and actually understanding the actual pathogenesis. So we're fortunate to be ahead of the game without knowing the answer to this very fundamental question.
So these next two questions for Dr. Hubert. Oh, first, what experience do any of you have with using hypnosis in MS treatment, and particularly combining with physical therapy or cognition or depression?
I don't know if I have not seen an article in that specific realm of hypnosis and then combined with enhancing exercise or being able to, maybe offset some of the side effects, the typical side effects of exercise. I'm not sure if anybody else has.
I have a very small comment. Self-hypnosis and self-visualization techniques are likely beneficial for a variety of different contexts. The big one that I think can be very useful is sleep disruption. Many of our patients, and many just people in general in the United States, have either a primary insomnia and or early morning awakening, and there are a variety of different approaches that can be used for this. Self-hypnosis can be useful for stopping smoking, losing weight, and a variety of other things. So I think the question gets at, is it conceivable that self-hypnosis is part of a generalized wellness program? And I think the answer is probably yes. But as Dr. Hebert alluded, I don't know that I've ever seen any data whatsoever that would have a specific, say, for this, do this with that, and you'll get a better outcome. But I would bet that it probably would if you can actually design a study.
Again, for Jeff, why at age 64 can I not participate in your clinical trials? And what do I have to do to get treatment from you to enhance my balance and challenges? And how does one get in touch with a knowledgeable physical therapist?
What was the first part of 64?
Getting clinical trials.
Age 64? Turn up the volume?
Closer to your mouth.
Yeah, no, I'll get this one right here. I'm sure you can hear me. Okay. Why can't I, at age 64, participate in any of your clinical trials? So I'll answer that one first. At this given time, the research that we've done does cut off at 64. The reason typically for that is, unfortunately, with research, we have inclusion-exclusion criteria, and that's one of them, and age. And I get what you're saying, because it's very difficult to then generalize to anyone that's above those ages. But what we're trying to do when we do these early studies, to really make sure that we're looking at the main component of the treatment, is that we want to try to control for any other confounding factors. And even though we're saying that, aging is a normal concept and is something that we have to take in consideration, at the same time, we want to decrease the amount of that contribution to maybe play into the results of the actual treatment. And there it goes.
Okay.
Just another small comment. Dr. Aber is absolutely correct in terms of the concept. We do have one study, however, not with Dr. Aber, but that specifically is looking at older individuals, relatively older individuals with MS, the DISCO MS trial, the discontinuation trial, which we did not really discuss today. And that is for people 55 and older, not younger, and is focused on looking at, with aging, how long is it necessary, or really necessary to use, or perhaps more really, is it safe to discontinue the disease-modifying therapies? And this is a concept based on many lines of data suggesting that relapse diminishes with age, new scan changes diminish with age, response to the therapies diminish with age, all of which are well proven, but it's not yet been shown that it is safe in that context where someone has not had a relapse, not had a scan change, but is aging. Is it safe to stop using the medication? So aside from actually answering that question, we're obtaining, interestingly enough, a variety of patient-reported outcomes, quality of life measures, and others in individuals 55 and older. And the hope is that, as just a side benefit, we will actually obtain a vast amount of information just about what it feels like to be 55 and older with MS. So there are some studies that do not have an age limit. This one particularly wants people who are not so youthful.
Can I interrupt? Is that any better in the back of the room, the volume? Yes? All right. Sorry about the troubles.
So the next couple of questions will be for Dr. Gross. The first one is taking a probiotic supplement or liquid helpful to the gut? Second one is, actually I'm going to hand the second one down to him and he can read it.
Okay, first question. Is taking a probiotic helpful for the gut? We don't know. It could be. I'd like to see some clinical trials that show that it is effective in measurable outcomes. But I think these things are so widespread out there. People are just going to go take a probiotic, outside of the context of a clinical trial. So it'd be helpful to get your feedback as far as what you've experienced with while taking these supplements or probiotics. Next question. Did you say that the new sequence of MS flares, new lesions, can pinpoint or give direction as to level of disability, physically, cognitively? Can we learn what specific therapies, physical therapy, medication, continue in relation to each lesion? As I kind of alluded to in the talk, there's kind of not a great correlation between the lesions that you see, the kind of typical lesions that you see on those flare sequences, the bright ones, and a person's degree of disability, that whole clinical radiographic paradox. I say there's not a great correlation. There is some correlation. We know that people who have a larger disease burden, on average, tend to do worse. But there are certainly people out there that have a whole head full of lesions that really are fine. You would never know that they even had MS. And so there is a correlation, but it is a kind of a small one. I think, one important thing that we don't really talk about all that much is that the location of the lesion matters a lot. The location and the size of the lesions that people have matters a great deal. And so if you have a particularly badly placed lesion in, say your spinal cord or your brainstem, you can become very disabled as a result of that, even if that really is your only, lesion, and you can have relatively no other lesions in your brain, and that would still cause a fair amount of disability. So I think geography makes plays a big role in that. And the other part of the question is, so it's kind of, do we direct resources to help with physical or cognitive disability based on the lesions? And I guess I would say not really. I mean, it more has to do with how the person is doing. So I look at the person first, kind of, what they're telling me and what I see when I do the examination. I think those things are far more important for figuring out kind of how we plan some kind of intervention as far as, rehab or what have you. I don't know if other people have other thoughts about that, but the final part of this was, can we learn what specific therapies, physical therapy, medication, cognitive stuff, in relation to each? No, I guess that was the same. That was the same part. Okay.
I would actually just ask a question also for Dr. Bakay. If she could comment for all of these other autoimmune disorders that she described, is there reason to believe that wellness approaches are going to be similar in terms of their helping in those contexts as well?
That's a great question. So absolutely. I think patients with autoimmune disease for sure do better with diet and exercise, and it overlaps greatly with what we've been talking about with MS. Same thing with smoking. We know smoking worsens disability and progression in MS, and it's the same for most autoimmune diseases.
Amanda, go ahead and keep that. A couple questions for you. The first one is, are tests like 23andMe useful for predicting MS or any other autoimmune disease?
Genetic.
Yeah, I'm not as well versed with those testing. They're not validated, and it's not for autoimmune disease specifically. The focus is on antibody testing rather than the genetic testing, and I think we have a ways to learn with that.
I'll answer that for the MS part of things. No, it is not useful. We know that people can have even a very high genetic burden, genetic risk factors that are associated with MS. You can have all of them and still not get MS. So the genes only get you so far. There's a genetic component to risk of getting MS, and then an environmental or non-genetic one, and it's that interplay. And so we can't predict based on somebody's genes who's going to get MS. I think part of studies like this, the RISE MS study, are going to help us identify other factors that could potentially be useful in determining who's among people who are already maybe genetically predisposed, who among them might go on to get MS. But at this point, just looking at if you had a whole genome scan of for yourself, and it said that you were at high risk for MS, I wouldn't. Well, first of all, I probably wouldn't even recommend that you get it. But if you did get it and it said that, I would be skeptical.
If I could, is this on? Yes, if I could just add a small comment. Some of you may have heard that there is a blood test that is being suggested to be useful for diagnosing MS. And I think it's fair to say that it does not live up to its statements. It has not been studied in a population of individuals who have a wide range of symptoms that may or may not be multiple sclerosis. So if you look at this blood test, it seems to correlate reasonably well with people who are already documented to have MS. That is one thing that's not particularly useful. We can diagnose MS perfectly well without the blood test in that context. What we would really like to have is either a test or some combination of different tests that would be more definitive and would be linked specifically to the pathogenesis of the condition. We just don't have that right now.
Okay, again, I'll try to speak louder, but this is also for Amanda. And it has to do with the antibody tests, and given that there are so many of them, should it be done more often in patients? Should there be some kind of standard testing? And it comes down to, his question is, if patients diagnosed with MS, Parkinson's, or other neurological disease, should they be asking for antibody testing?
So unfortunately, with the 25 minutes I had, I did not get into the nuances of antibody testing. But in that one slide, there was an asterisk around some of the antibodies. So some of the antibodies that we know about, they're not even commercially available. Best testing depends on the antibody. So sometimes a blood test is the ideal test. Sometimes a spinal fluid is the ideal test. And it really comes down to the sensitivity of that particular antibody. For patients that present with syndromes of, so multiple sclerosis, for example, but there's some red flags. Like I said, they have both eyes involved at the same time with optic neuritis. That is when it is important to think about those mimickers and do those antibody testing. So for sure, patients like that should have testing for NMO antibody. They should have testing for MOG antibody if the NMO is negative. In terms of other neurologic diseases, I get into this in a little bit more detail if anyone's interested on the webinar that was announced after my talk. There are clues when patients present with certain neurologic syndromes. So we'll use Parkinsonism, for example. It comes down to the demographics and the time course. So if it's a patient that, say, is in their 30s, that would be atypical for Parkinson's disease. Say they have symptoms of cognitive and behavioral changes that progresses rapidly over weeks. That would be atypical for something along the lines of what you would expect for dementia or Alzheimer's. So it's those clues that can sometimes help guide your antibody testing.
Okay, I'm going to run through a few questions here just because they're fairly generic. One question is, if you learn that your brain volume predictors are not good based on MRI, what do you do about that? You get on a highly effective therapy. So we will be presenting some data in Berlin at the ECTRIMS meeting, which is a large international meeting on MS, from our studies here that shows that people who have been on highly effective therapies, which includes Tysabri or Gilenya, and probably Ocrevus and rituximab, that if they've been on it for 3 years or longer, their rate of brain volume change has normalized. It's the same as healthy controls. So we do think that over time, it may take a couple of years, but over that period of time, the rate of brain volume change can normalize on these highly effective therapies. That's probably not true with interferons and glutamerastate. And another question about, have studies shown that the effect of DMTs can increase longevity in terms of work life, how long people can stay employed? The answer is yes. The drug that's been studied most in this is Tysabri, because it's been out for more than 10 years. But the data is emerging that we are fundamentally changing the course of disease, and patients, particularly patients treated in early phase disease with these highly effective therapies, become remarkably stable in our experience, and I think that's going to be confirmed in data that's coming out soon. So the newer therapies can definitely change the course of disease, and they can do it in a way, from a risk standpoint, that's not particularly significantly more risky than using interferons and Copaxone if patients are followed appropriately and selected appropriately. Are we seeing clinical differences between rituximab and ocrelizumab? No. Sorry to Genentech, but no, we don't see any difference between them. Question is, how about brain volume MRIs? Do we need to get insurance to pay for these? Well, the reality is they already do in our center. We get three-dimensional volumetrics. It does not increase the price of the MRI. It's a software package that the radiology department licenses to help them get further analysis on it. So it is possible to get three-dimensional volumetrics done as part of a routine MRI. How useful they'll be in terms of following disease, we don't know yet. But in terms of sort of understanding where people are at the current moment compared to age-matched healthy controls, it does provide that information. So this is a question for whoever would like to take this. It says, after 13 years on Tysabri with no relapses, but JCV antibodies are positive, level 7.6, although decreased to 5.6 over the last 6 months. Should Tisabri be continued, or should I switch to some other drug? And if you do switch, particularly from, like, say, Tisabri to Ocrevus, how many weeks do you have as a washout?
Yeah, I'll take that one. The biggest change in our function with the use of natalizumab Tisabri over the course of the last 10 years has been the development of the JC virus stratify study that allows us to determine if someone has been exposed to the virus, the JC virus, which is associated with PML, progressive multifocal leukoencephalopathy, primarily in natalizumab patients, but also in patients who take fingolimod, Gilenya, or dimethylfumarate, Tecfidera, and a whole host of other medications that are used for other purposes as well. So and we know that the risk with natalizumab, specifically, of developing this complication, this PML, this brain infection, is associated with a variety of factors related to either the patient or to the use of the drug or to the nature of the interaction with the virus. The biggest is being positive on that test, which is not a perfect test, but which is highly predictive of risk of developing this complication, especially if you have a higher so-called index or amount of the antibodies directed against the virus. In addition, prolonged use, longer than 2 years, is a risk. In addition, if you've used prior chemotherapies or other immunosuppressants, that's a risk. Probably there are some other risks as well. Perhaps being over the age of 50 is a risk. Being smaller is a risk because you probably saturate more of the receptors on the white blood cells and make their surveillance for viruses diminish. So there are probably a number of different factors, but for someone who's over the age of 50, has a high index associated with exposure to the virus, and a prolonged use with natalizumab, their risk is quite substantial of developing PML. You may be able to mitigate that risk by doing a couple of things. One prominent thing that has been suggested, which is possibly true but not certain, is that you might be able to use extended dosing. And there have been multiple extended dosing studies done, most recently looking at the so-called TOUCH database, which shows that if you use extended dosing, you can reduce the risk of PML in individuals by about 94%, but do not eliminate the risk. You can reduce it, but not eliminate it. Prior to the introduction of fingolimod, Gilenya, in 2010, we did not have a lot of options for individuals who had risk of developing PML on Tisabri. We also didn't have the test available then. So with the introduction of Gilenya, quite a few patients who were on the drug, on natalizumab, Tisabri, for a prolonged period of time would actually switch over to Gilenya. And then now we have multiple other drugs which have also become available, and most prominently, more recently, the use of rituximab off-label and ocrelizumab now, which is approved by the FDA, which appears to have a very low, if any, risk of developing PML. Rituximab has been used for other purposes. Small number of cases of PML have been seen, especially in older patients with cancer or rheumatoid arthritis, who use multiple drugs, use rituximab at high doses more frequently. But in our patients, as far as I am aware, no patient who has not been exposed to fingolimod or to natalizumab and has used either rituximab or ocrelizumab as a solo agent, no one has developed progressive multifocal leukoencephalopathy to date. So in our practice, a substantial number of people, as opposed to using extended dosing, almost all of our patients have switched over to ocrelizumab or rituximab to mitigate the risk of PML.
Maybe you want to add about. Well, this is your baby, so I was.
Go ahead.
Yeah. Well, because I forgot what exactly the details were, but if somebody has been doing well on treatment for a number of years and is over a certain age, they might qualify. I think it's 55, correct? Yes. Yeah, you would qualify for potentially for the DISCO MS trial, which is randomizing people to continue their disease-modifying therapy or discontinue their disease-modifying therapy. It is not blinded, so you know which arm you are in. And then with that information at the end of the trial, we'll be able to know whether it is indeed safe to stop people who are above a certain age who have been stable on treatment for some time, because as of this point, it's very difficult to say whether even, I mean, we know based on Dr. Corboy, what he mentioned, the natural history of the disease, that it's less likely to have relapse, is less likely to have new MRI activity, the kinds of things that these treatments would be beneficial for, and the risk, as we talked about, such as with PML, might be increasing as we age. So it makes sense to have some kind of trial to see whether it's okay, to stop disease-modifying treatment.
Just
Thanks for the plug.
I would like to make just one summary point from what they said. Basically, if you're positive for the JC virus, there are other therapies that are substantially safer and just as effective. I don't personally treat people who are JC positive because of that risk. And in this particular case, the risk of developing PMLs, at least 1 in 200, and if they've been exposed to chemotherapy, can be 1 in 80. So there are better ways to treat the disease at this time rather than treating people who are JC positive with natalizumab. There's a question about neurogenesis therapies. Neurogenesis is the ability to generate new neurons. The only therapy we have to generate new neurons right now is exercise, and there's evidence that that can do that in the hippocampus and certain other areas. But as Jeff mentioned, there are growth factors that we might be able to use in the future to increase that. And then, we're told we're out of time, but the clock's still running though. So we'll end up with the most difficult question here, and any of you guys can answer that one, is CBD oil, not marijuana. Do we have enough information to make a recommendation?
Yeah, so this kind of gets back to my point about marijuana. So in general, we need more data to be able, before we can make a kind of broad recommendations to people that yes, it's okay to take CBD. On an individual patient basis, I have suggested, especially for people who are struggling with chronic pain or significant spasticity, I have suggested that it may be an option for somebody to try. And people have gotten back to me in certain cases that it has been helpful for those things. And so it's not certainly for everybody, but in select cases, it might be something that could be beneficial to be added on.
I would just only add that there is a product, I'm not sure I got the name right, so I apologize if I butcher the name. I think it's Epioladex, which is a CBD product which has been studied in especially children with horrible seizures. And the studies have shown that there is benefit associated with this. And this is an example of where the data is available, whereas for us, the data is unfortunately not available as much as we would like. But this is a molecule that's going to be, it's in front of the FDA now, should probably get approval in the next couple of months. And there's another variation of a hemp product, Sativex or Sativex, on the market in the UK and I believe in Canada, which is a mix of CBD and THC, which is approved for use with spasticity. So the reality is that there is data in some realms, there's not enough data, and it would be nice if we would be able to, in a more simple fashion, be able to study these products so we can say yes or no that they're helpful or not, as opposed to wandering in the desert with no good data.
Okay, that brings us to the end of the program. Again, I would like to thank my colleagues for participating, but I'd mostly like to thank all of you for participating. And there are questions we did not get to, and if you still would like to pursue them, my colleagues will be up here for a few minutes. Feel free to come and talk with us. So again, thank you all for coming. We hope it was useful.
Vollmer, Dr. Hebert, Dr. Corboy, Dr. Gross, and Dr. Piquet. And like Dr. Vollmer said, thank you most of all. You made this event really great today. It's so good to see all of you here. I hope it was valuable to you. And again, a reminder to fill out your evaluation form before you leave and drop it in the box, or you can just leave it on your table here. We do hope to see you at some upcoming events that we have planned. Our MS for MS, our annual summer of hiking. It's sort of a do-it-yourself approach. We have our kickoff on June 8th at the Rocky Mountain MS Center, so be sure to join us there if you can. More information on our website. And then our gala, save the date for that, which is on September 8th this year. So just wanted to flag that for everyone. And again, thank you so much. Enjoy the rest of your weekend and let us know if you have any additional questions. Bye-bye.